All right, good morning, everyone. Welcome to the special meeting of the Placer County Board of Supervisors, Tuesday, August 18th. Appreciate you all being here, and we will start. Actually, why don't we go ahead and give Megan the public participation procedures, and then let's start with the flag salute. So, Karen, if you would lead us, that would be great.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you. So, Megan, if you would read the public participation procedures, that would be great. Thank you.
In order to protect public health and safety of our Placer County citizens, the public comment for the Board of Supervisors meeting will be offered virtually through a Zoom meeting webinar utilizing the raise hand function. To provide public comment, please raise your hand when the chair announces the item. Thank you.
Thank you, Megan. And we'll move on to our first item, which is approval of CARES funding for restaurant and bars. And I believe we have Jeff Brown on the line. Is that correct?
This is Jason Philippe.
Oh, good morning, Jason. Thank you for being here. Take it away, please.
Of course. Good morning, Chair Gore, supervisors. I'm Jason Philippe, your Health and Human Services Deputy Director of Environmental Health and Animal Services. And I'm pleased that my first board presentation before you is on the topic of assisting our local businesses. Darlene King, HHS Deputy Director of Administration, will also be available for questions. I'm here today to share a report about CARES Act funding usage for restaurants and bars in Placer County. The CARES Act was signed into law March 2020, with funds available for reimbursement of eligible COVID-19 related expenses. At the July 28th board meeting, interest was expressed in an assistance program for restaurant and bar establishments because of COVID-19 pandemic impacts. Staff set out to research how many establishments would be eligible, amount of potential assistance for each, and a way to disperse these funds expeditiously. As you may know, environmental health permits and inspects all bars and restaurants in the county, including incorporated cities. Currently, there are a total of 1,221. This would allow for $1,000 in grant assistance per establishment if all applied and ultimately qualified. Due to the effects of the stay-at-home order, it appears virtually all bars and restaurants will qualify. We're proposing to use Environmental Health's long-standing working relationship with restaurants and bars, including their contact information, to notify establishments with grant instructions directly. IT has developed an easy-to-use electronic form to streamline the process, and our PIO group has prepared draft communication and website page to support this initiative. Finally, our HHS financial group is prepared to process and disperse payments. And if I may add, it's been a pleasure working with so many hardworking and dedicated county staff across several departments on this initiative. We are prepared to implement this program this week if that's the direction of this board. This concludes my presentation, and I'd be happy to answer any questions.
Thank you very much, Jason. I did actually forget to mention that Supervisor Euler is joining us via Zoom. So just so that folks know that he's not on the dais, but he is joining us via Zoom. Questions for Jason on this item? You know, Jason, I have one question, and that is coffee shops. If they have seating, they are included as well, correct? They would be considered a restaurant if they're a coffee shop?
That is correct. They would be included.
All right, great. Thank you. And then let's open this up to the public. Are there any comments from the public?
Currently there are none.
All right, no one there. Thank you very much. I really appreciate this being brought to us. We had received input from local restaurants, actually from our chamber, saying that our restaurants were really hurting, especially because they closed down, they opened back up, they spent money putting together ways to keep their patrons safe, and then they had to move everything outdoors, which was an additional expense. And so this might provide relief of about $1,000 to each restaurant, but I do think that especially when money is tight, I think this is a really good use of our CARES dollars, and I really appreciate staff bringing it forward to us. Ditto. All right. So with that, may I have a motion, please?
Second.
A motion by Supervisor Holmes, second by Supervisor Wygant. All those in favor? Aye.
Aye.
And I hear an aye from Supervisor Euler. So motion carries 5-0. Thank you very much. All right. We have 3 minutes before we start with Dr. Sisson. And so before we start with our hearing, I do want to say thank you. We do have a number of speakers on the line, experts who also have medical backgrounds, psychiatry backgrounds. So we appreciate you all being here. So I want to share that right now. And we will introduce you all after we get an update from Dr. Sisson. But before we move on, any members from the board want to have a report? It looks like Supervisor Holmes.
Yes, I just wanted to point out to the members that today is the 100th anniversary of the ratification of 19th Amendment. So here's to you, ladies.
Thank you. And sort of bad on Cindy and myself for not actually saying that women have now had the right to vote 100 years ago, and you know, we're just taking over, which is
It ain't been the same.
oh, but so much better, Supervisor Holmes. So much better.
And we're allowed to serve
Right.
in elected seats.
So thank you for reminding us of that. I appreciate that. Supervisor Gustafson, any comments?
That was it.
You know, as we're waiting to get to the mark of 9:10, just a couple of things. I know that our residents are aware that we may be having power shutoffs, and we've got unprecedented high temperatures, a heat wave. So just a reminder, folks, to stay cool, check on your neighbors. We do have cooling centers in our community. We have a cooling center here at the Auburn Library. We also have a cooling center in Roseville at the Tower Theater. I believe there's one in Rockland as well. Where is that? Do you know, Tom?
I'm not sure where that one is.
So I just think it's really important, if you do not have air conditioning, if you can go to some place where you can stay cool, I think it's really important. You know, keep your pets safe, but just really, I encourage our residents to look out for your neighbors. It is hot out there, and so we just want to make sure that everyone takes care of themselves. We also have to be concerned about wildfire. We've got CAL FIRE out there on the lines. There's been a number of fires already, and so just a reminder to folks, keep your eyes open. Don't do something that would cause a spark, right? Don't use your lawnmowers and weed whackers. Please be careful because really other people's lives, our properties depend on us taking care of one another, and this is just a challenging season right now, so we appreciate folks being aware and taking care of one another.
And continuing to sign up for Placer Alert, so that if there is a fire and any evacuations, I know there's quite a bit of influx of evacuations last night out of Grass Valley area and the surrounding areas, also up by Loyalton, so please stay tuned for Placer Alert for the right directions as to what to do.
You know, Supervisor, I'll just, I just received, it's the Rockland Police Department locations where their cooling center is located, so for residents there. I will share with you, if there is an interest for a cooling center, we have our 211 system up and running. Information's available to any resident in the county regarding information, whether it's cooling or if we have run into some fire situations. And yeah, I do have to give a shout out. I think CAL FIRE's taken the lead on a number of issues in a very short period of time this week. And unfortunately, we're probably going to see more of these fires cropping up over the next week and probably next couple of weeks as it just gets so dry out there. So be diligent, but information's available for residents through our 211 system.
Great, thank you for the reminder. All right, let's move to our 9:10 timed item. It's a COVID-19 update. We'll start with an update from Dr. Sisson. So good morning, Dr. Sisson. Thank you so much for joining us this morning for this special meeting. I appreciate your time.
Good morning, and thank you for the opportunity to be here this morning. This morning, I will update your board on actions at the state level that have local impacts, case numbers and rates, hospitalizations, deaths, as well as outbreaks in our long-term care facilities. I'd like to start by describing my recent advocacy efforts to the state. On Wednesday of last week, I wrote a letter to the California Department of Public Health asking that they consider revising the July 13th state public health officer order regarding business rollbacks. The current order requires certain businesses and counties on the state's monitoring list to close indoor operations until further notice. I propose that the order be revised to allow affected businesses to resume indoor operations once a county has been off the monitoring list for 2 weeks. This would be consistent with recent state guidance for reopening of schools for in-person instruction after a county is removed from the monitoring list. As currently written, the order does not incentivize the business community to support getting off the monitoring list because getting off the list is not linked to the lifting of restrictions. From what I understand, CDPH is considering the request. One week ago, Placer County Public Health released the state-defined school waiver application for elementary schools. To date, Public Health has received 7 applications from private schools. Public Health is advising each school as they seek to satisfy the state-identified requirements. Moreover, Public Health and school superintendents have formed a work group to create a collaborative plan to ensure rapidly available test results for both ill students and staff. Our first meeting was yesterday, and we're meeting again this afternoon. On August 7th, the state released guidance for institutions of higher education. While the state does not allow indoor lectures in counties on the monitoring list, indoor labs and studio arts are allowed if substantial physical distancing is possible. Let me say a few more words about the state's monitoring list. Placer County has remained on the monitoring list since July 9th. The state recently froze the monitoring list for more than a week due to electronic laboratory reporting issues. Yesterday, however, the state felt confident enough in its data to unfreeze the list. This morning, CDPH shared with me that our indicators have fallen below state thresholds for 3 consecutive days. This means that Placer County will be removed from the monitoring list tomorrow. Yes, you heard that right. We're coming off the monitoring list. If Placer County remains off the monitoring list for 14 days, all K through 12 schools may choose to reopen for in-person instruction under the modifications outlined in state guidance without needing a waiver from the local health officer. As I mentioned earlier, due to the way that the state order is currently written, businesses like hair salons and places of worship will not be permitted to resume indoor operations following the county's removal from the list. I will continue to advocate to CDPH to link removal from the monitoring list to reopening of businesses. Let's turn our attention to Placer-specific data, beginning with hospitalizations. Hospitalizations have held relatively stable over the last 2 weeks. We currently have 64 confirmed COVID-19 cases in Placer County's 3 hospitals, 95% of whom are hospitalized because of COVID-19. At the request of this board, Placer hospitals are now reporting the number of new COVID admissions in the previous 24-hour period daily to public health. Yesterday, there were 9 new COVID-19 admissions, down from a high of 18 on August 3rd. There are currently 15 confirmed cases of COVID-19 in the intensive care unit, 87% of whom are there because of COVID-19. Bed availability in Placer's 3 hospitals remains low. There are only 8 total adult beds available, with only 6 available in the ICU. 2 hospitals have surged their regular adult beds, expanding capacity as needed to meet demand. There are now 2,625 laboratory confirmed cases of COVID-19 in Placer County. 28 Placer County residents have died of COVID-19, including 8 in the last week alone. Deaths are a lagging indicator, and while case rates and hospitalizations may have peaked, we predict that deaths will continue to climb. All of the deceased so far had underlying conditions, with many of them residing in long-term care facilities. Cases in long-term care facilities continue to rise. Currently, 7 skilled nursing facilities are reporting 1 to 24 cases each in staff and residents, including 15 new cases in the past week. In addition, 6 other long-term care facilities report 1 to 11 cases each, including 6 new cases in the past week. Public Health is conducting extensive testing and surveillance in these facilities and has engaged the California Department of Public Health to provide ongoing technical assistance to skilled nursing facilities in particular. However, the best way to protect vulnerable residents in long-term care facilities is to keep the case rate low in the general community, since that is where long-term care facility employees come from and return to every day. Placer County Public Health has received nearly 47,000 initial test results to detect COVID-19 infection. This indicates that over 10% of the county's population has been tested for COVID-19 to date. Locally, we measure the 7-day average testing positivity rate at 9%. Placer County Public Health has been working with the California Department of Public Health to understand why our local calculations differ from the state's so that we can better understand and predict our placement both on and off of the monitoring list. We've learned that the state currently has our positivity rate below the 8% threshold at 5.2%. This is likely because the state does not deduplicate results when calculating positivity rate, whereas Placer County does. We have requested that the state share their detailed methodology with us so that we can replicate their approach in our own reporting. We'll be shifting to the state's method on our daily dashboard, and will likely also shift to reporting case rate by episode date rather than by date of specimen collection, a distinction that I discussed at our last meeting. We expect to implement those changes later this week. I have good news to report on the testing front. Testing turnaround times for lab results have improved. The state's testing contractor, OptumServe, which uses Quest as its laboratory, is reporting decreases to 4.6 days from 7 days previously. One large health system has decreased to 3 days from 4 to 7 days for outpatient testing. The 2 OptumServe sites in Rockland and the Tahoe region are still open. Both are operating at or near capacity, and the number of no-shows has decreased in the last week. Wait times for appointments have also improved from the 7-day wait I previously reported to your board. Appointments are now available within 1 to 2 days at each of the Placer locations. Placer County is following state testing prioritization guidelines and continues to recommend testing only for people with symptoms or who are close contacts of cases, part of an outbreak investigation, or who live or work in a high-risk setting. In summary, COVID-19 continues to circulate throughout the Placer community and sadly has resulted in more deaths. While we're only a little over halfway through August, it has already been the deadliest month to date for COVID-19, with 11 deaths recorded so far. Our forthcoming removal from the monitoring list is a great sign, and if we remain off the list for 14 days, this will allow schools to reopen in person. I urge our community to continue to exercise healthy habits so that we can stay off this list and allow our schools, and hopefully also some of our businesses, to move forward with reopening. To slow the spread of COVID-19 and prevent further disease and death, we continue to recommend the following health precautions. Avoid gathering with non-household members. Stay 6 feet apart from people you don't live with. Wear a face covering in public. And stay home if you're sick or you've been exposed to somebody with COVID-19. Thank you for your time and attention this morning, and I'm happy to answer any questions.
Thank you, Dr. Sisson. I appreciate that. I think what we'll do, unless there's any clarifying questions from our colleagues, what we'd like to do is, since we have some people lined up to speak, we are going to go ahead and hear from our panelists. That way we've got folks who are calling in and they've got tight schedules and patients to take care of, et cetera. So what I've asked is that Shanti Landon, who works for us Supervisor Wygant has been able to reach out to a couple of folks, experts in their field, so we're going to hear from them. We also have a couple of speakers from some local hospitals and a local university. So Shanti is going to introduce our speakers, and then we'll hear from each of those. We'll hear from each panelist. If you have some clarifying questions of that panelist, we can go ahead and take those comments or questions at that time. That way, if any of the panelists have to drop off the call for work, we have an opportunity to ask some clarifying questions. We'll finish up with our panelists, and then we can go ahead and open it up to comments or questions from the public. All right, so Shanti, if you will introduce our first panelist, please.
Sure, great, thanks. First, I just want to say thank you to the panelists. We have a couple that are joining from Europe, and so we really appreciate, with the time difference, that they're taking the time to come speak to us today. So first up is Dr. Michael Levitt. Dr. Levitt is a professor of structural biology at Stanford University. He's also a Nobel laureate, receiving the Nobel Prize in Chemistry in 2013. Since January 2020, Dr. Levitt, his Stanford group, and an international team of volunteers have worked tirelessly on data analysis of COVID-19. Dr. Levitt has been published numerous times in the National Institutes of Health and National Library of Medicine. He is well-versed and researched on COVID-19 and its behaviors. He received his PhD from Cambridge University, and we are truly thankful for the time he's taking today to provide his input here at the board. Welcome, Dr. Levitt.
Hello, I think my camera is muted. I'm not sure how okay, I can unmute it, sorry. Great, so you see me against San Francisco background, basically because I'm in a bedroom, and I thought that was more appropriate. So basically, firstly, I wanted to say that I'm appearing here, I think principally because of Shanti and also Julie Parsonette, who's another speaker. I actually wasn't sure what Placer County was, but when I found out, I was actually even more happy because I'm an avid hiker and skier, and I'm sure I've been there many, many times. I was also impressed today looking at the internet to see that things are very, very well organized in terms of your net presence, and I think this is all a good sign. So basically, I have been looking at COVID for a very long time, but I should say, as has been said about me numerous times, I'm not an epidemiologist. I don't have an MD. I do work at Stanford Medical School, and I've been there for a long time, and I am well-versed in looking at data. So essentially, my approach has been to look at the data without any prejudice and try to see what it tells us. And I think Placer County, like many other places in the United States, are at a difficult junction now because there's basically a choice between, so I think we can probably all agree that the right thing is something that minimizes total suffering, total loss of life, and so on. I mean, I think that's probably the criterion that we could all agree with. It's not necessarily minimizing number of reported COVID cases. Keeping hospitals from collapsing is also an important criterion. But I think if we had to choose between saving lives and saving hospitals, we'd probably bend towards saving lives. Difficulty is that it's actually easier to do the politically correct thing than the right thing. And unfortunately, this is a distinction for coronavirus. So let me just try to give you some idea about that. I think firstly, the virus is a respiratory virus. It's not in the same viral family as flu, but it affects people. It seems to have seasonality. Both flu and corona are terrible diseases. I know very early on when I was speaking about coronavirus at Stanford Medical School in early February, they said, realize again that flu is a terrible disease that has a massive burden of death. People who get flu often suffer for many years afterwards. So I think that's an important point of departure. The trouble is that the politically correct measures we take to deal with COVID that involve lockdown, closing of schools, they would be great if they didn't have any price. So if everybody was homeschooled, if we had been using Zoom for the last 15 years and nobody really felt any need to see people, if all restaurants were in delivery business and there were no stores except for Amazon, we would be fine. There would be very little impact of the lockdown. Unfortunately, that's not the case. And I know from my own experience, I've been working with a multinational team, and the biggest problem has been just the time differences. I have one team member in Shanghai, another team member in Stanford. I myself am stuck in Europe, and it's really ever hard to be awake at the same time. And not only that, if we are awake, for one person it's morning, the other person it's evening. So there's definitely a need for the good old way of doing things. And I think the difficulty is that all of the measures we take have a price. You can imagine what the social cost of missing schools is, what's the economic cost of closing down businesses. These things translate into lives. When there's a recession, as there was in 2008, people died. It's not that anyone caused the death, but basically when people are financially desperate, they take their own lives, they drink more alcohol, they smoke more, they drive more recklessly, and indirectly, we're causing death. So in some ways, it's very important to realize how to balance these two things. And I think it's a very difficult thing. It depends on, a personal matter. You can say, well, we know that there's going to be more death, but politically, we just simply have to play the game. We have to basically lock down. We release the lockdown a bit. When the virus cases go up, we increase the lockdown. And we basically dance around the number of cases. And I think that what completely broke this model for the world was the country of Sweden. Sweden decided pretty early on, I think it was in middle of March, not to go for the lockdown game, but try to get everybody infected. Now, it's pretty daring back then because the same people that predicted 250,000 deaths in the United States, 2.5 million deaths in the United States, predicted 60,000 deaths in Sweden, which is a large number. It's something like more than a year of natural death. Sweden basically said that they didn't believe that. At least they acted that way. They went for saturation. They had COVID running quite rampant in their country until they got to about 6,000 deaths, something that I happened to predict very early on because we'd seen similar levels of death as a percentage of population in other countries. And basically, they're now in a situation where they have no longer any cases, but more importantly, they feel they've reached some kind of saturation. I'm not going to call this herd immunity because herd immunity carries many, many connotations. But basically, given their population, given their age structure, given the rural, Sweden is a fairly low density country for Europe. It's got a population density that's more like the USA, not quite as low as that, and so on, that they've reached a level where the amount of infection coupled with natural susceptibility, it seems that coronaviruses are not new. We all get sick all the time with the coronaviruses that are basically common colds, and the body has an immunological system that basically can detect a cell that is being filled up with coronavirus of any kind and kill that cell. So basically there are other measures. So Sweden took this approach, and much to everyone's surprise, it succeeded. Now, I've been based partially in Israel during this period, and in Israel they had a very sharp outbreak in March. They locked down very severely. They ended up with something like 60,000 cases and about 300 reported deaths. I should say that a very important thing with COVID, which might not be politically correct, is that people can die from COVID or with COVID. And when there are comorbidities, it's very likely with COVID. Now, how can you tell this? You just simply look at the total all-cause excess deaths. And although Israel so far has had something like 500 reported COVID deaths, the excess deaths, the total number of deaths from all reasons this year is no higher than the same period was last year. So you could say that the people who died of COVID would have died otherwise, or other people would have died. Or you could say that the lockdown saved as many lives as people died from COVID. The fact is you cannot detect COVID death. Now, if you apply the same calculation to the USA, it seems very likely that the USA is going to have a total of 170,000 excess deaths. That might sound like a very large number. It is a large number. It's unclear whether it's a factor of 2, higher than the flu from 2017-18, but it's not an order of magnitude higher. And 170,000 deaths is about the same natural death as you'd get in about 3 weeks in the United States. In the United States, there were a little bit less than 3 million deaths a year, natural cause deaths. So basically, the corona has caused about an extra death equivalent to about an extra month. Exactly the same thing was seen in all of Europe, where we had some very heavily hit countries like Italy, United Kingdom, and so on. Their total excess death is also very close to 170,000. This turns out to be something like 500 people dying for a million population. So in any case, all of this is just sort of background. Placer County seems to have a case death rate of a little bit more than 1%. You have almost 100 times more cases as deaths. I looked at the county, and I think the age profile might be slightly higher than the rest of California. The county seemed to score very, very well on its health profile. It was in the highest percentile of counties in terms of their health. So now I think you need to think what to do. Now, what we felt for Israel basically had this first case, and they locked everything down and did a huge amount of damage to the economy. Basically, when I was there, restaurants are closing and not reopening, et cetera, et cetera. I guess like in the USA, there was 6 months of aid for people out of work, and this is now ending. In any case, there was a second wave that started about a month ago, maybe 2 months ago. Cases were ramping up very rapidly. And then we started to see that the deaths were lagging behind. And then came the thought that perhaps coronavirus, COVID, like influenza, is actually seasonal. That means, we all know you don't get flu in the summer. The question is this: why don't you get flu? So one explanation would be that the virus just cannot, it hates the heat, and the virus just doesn't travel between people when the weather's hot. The other explanation could be that we're actually getting infected. There are plenty of flu cases, but no one is feeling sick. And as a result, we're not getting any sick people. So I think that I actually put out a Twitter about 6 weeks ago saying a crazy idea, saying that perhaps COVID was actually being transmitted in the summertime, but was less dangerous. And this actually gives you an opportunity because you can infect more people for much, much less death. Typically, in Israel and other countries, the death rate in the summer is something like a third or a quarter of what is seen earlier on. So as a result of this, together with colleagues in Israel, Wadi Kimron and Rigavish and Ifat, I've forgotten her name, I'm sorry, Abadi, we proposed that maybe Israel, instead of trying to fight the virus, should let the virus bring up the number of people infected to a level that we think ensured herd immunity, or should things stopped in Sweden. And this turns out to be between 15 and 20% infected. So Israel, we presented this view to many, many ministers. Nobody agreed with us. But the fact is in the last month, Israel has had about 10 deaths a day, which is more than they were having at the height of their lockdown, but they're doing nothing. They have about 1,500 or 1,600 cases a day. And again, they're very happy. The hospitals are not being saturated. And my feeling is that they've decided, perhaps for political reasons, not to cause any more trouble with the people out of work, to actually go for this level of saturation. So it seems that no one has told us, you guys were right, we believe you, but the numbers are certainly pointing in that direction. And I think that, of course, if everything I'm saying is wrong, and come 1st of November, there's a massive outbreak of coronavirus, COVID in Sweden, and people start dying like flies, and there's no vaccine, then you would have to revise things. I think this is unlikely. People, again, seem to have learned from influenza that influenza comes back. But polio, once you're vaccinated, doesn't come back, nor does measles. And it turns out that influenza is a especially devious virus. It's much smaller in terms of its information than corona. It's about 1/3 the size. But even more surprisingly, instead of having so I worked out that coronavirus I think it's 25 tweets in terms of characters. They're very small. I mean, viruses are not very complicated organisms. They have very little information. But in the case of influenza, the information is actually broken up. Instead of having one paragraph, it's actually 7 sentences. And this means that different virus strains can play with the sentences to mutate them. And the reason influenza comes back and can't be dealt with is that it mutates much, much more rapidly than other viruses. Perhaps if one sentence doesn't mutate and it's needed, it can borrow it from somebody else. But in some ways, influenza is a very, very devious virus coming back the way it does. Most other viruses, I would say almost all other viruses, aren't able to mutate so quickly and outfox our immune system. So I think it's unlikely, but of course, everything is just probabilistic. It's unlikely that COVID will come back in the fall. It's also clear that countries that are now being affected by COVID in the Southern Hemisphere are actually in an interesting situation because their epidemics just keep on rolling on, but their excess death is not increasing. And it's fairly clear that people who would have been labeled as dying from flu are now being labeled as dying from influenza, are now dying from COVID. And I think it's important to realize that COVID is the first disease where we've made extensive use of virus RNA testing, polymerase chain reaction, or PCR. If we were to apply this measure to an influenza season, we would find 20% of the people carry the influenza virus. And this means that 20% of the deaths in that period could be labeled as deaths from influenza, when in fact they're deaths with influenza. So if we did this, we would find that influenza deaths were way, way higher than COVID deaths in many places. So again, this makes it very hard to really know what to do. So I think the decision that you face, and it's a hard one, I would say it's really good that you're helping your businesses. I think the burden is massive. I think you're going to need to help social services, help people who are, be very careful about what alcohol consumption looks like, what smoking looks like. You don't need people to smoke very much to actually have a risk of dying that well exceeds that of COVID. So, overall, I think it's a difficult decision. I'm not sure that it's politically feasible for Placer County to do something like was done by Sweden or was done by Israel. That might be the right thing to do. But again, I think you probably need to carry on like you're doing, but really realize that lockdown is killing people. And, you've had 28 deaths, I don't know over what period, let's say over 4 weeks. When in 4 weeks, you would normally have, 280 deaths. I think you have about 70 deaths a week, about 4,000 a year, I guess. I couldn't find this number, but I'm assuming a mortality of around 1%. So basically, under those circumstances, you've had maybe 10% of the people who are dying in this period died with or from corona. And probably the number that really died from corona is a small fraction of that. So bear that in mind, but also bear in mind the damage that is caused by all the restrictive measures taken. We've never applied measures like this to influenza, and for good reason. These measures are costing enormously. I guess that's what I wanted to say.
Thank you very much, Dr. Levitt. Really appreciate your comments and your insight. Very helpful. Do any of our colleagues have any clarifying questions? All right. Thank you so much. We are going to move on to our next panelist. Shanti, if you'd introduce them.
Yes, up next we have Dr. John Ioannidis. Dr. Ioannidis is a professor of medicine, epidemiology, and population health at Stanford University. He's one of the most cited scientists of all times in scientific literature. His current research at Stanford covers a wide agenda, including meta-research, large-scale evidence, population health sciences, and predictive medicine and health. He has received numerous awards, including the European Award for Excellence in Clinical Science, and has been inducted into the Association of American Physicians and the European Academy of Cancer Sciences. He received his Doctorate of Science and medical degrees from University of Athens School of Medicine and his residency from Harvard University. Welcome, Dr. Ioannidis.
Thank you for this very kind invitation and for giving me the opportunity to share some thoughts about the current situation. and how it might pertain to specifically to your county. I have to say that I tried to learn about the situation in the county, looking at the dashboard and the information that is extremely well organized, and I want to congratulate you for this. I also see that you're giving serious thoughts to balancing the benefits and the harms of different interventions. Clearly, we are dealing with a major crisis with COVID-19. It's a crisis that is unprecedented, that we don't know the exact depth and breadth and consequences that it would lead to. We should be prepared for surprises. We don't know everything about this virus. I think that we're learning. I think that there is tens of thousands of scientists who are doing great work trying to compile information and evidence to guide us through the crisis. But we still don't know a lot. So I think that a cautious approach where we try to use the best evidence and the best estimates about different features of the virus and the pandemic and the measures that we're taking, but revisiting those based on what new types of insights we get might be the best way forward. As my great colleague Michael Levitt said, this is a major crisis that the measures that we're taking can have great consequences as well. It's not just the virus. The measures that we're trying to take to stop this pandemic, to do something about saving lives, can actually kill people. And the major question is, how do we save more lives? How do we optimize our chances of fighting the pandemic efficiently, minimizing loss of lives? I'm not going to use translations of lives into dollars, but every action that we do has consequences eventually on human lives. Lockdown, shutdown, shelter in place have tremendous consequences on health. They have tremendous consequences on mental health, for example. A recent study that was published a couple of weeks ago showed that if you look at suicidal ideation, 26% of our youth have thought of committing suicide in the last 30 days. I think that this is astonishing. It is more than double or triple the typical rate in this age group. Across all age groups, we see the same pattern. Essential workers, minorities are even at higher risk for this type of morbidity. If you look at anxiety and depression, about 62% have anxiety or depression among our youth, and also the rates are very high across the entire population. So these are data that are very difficult to translate and compare against the number of deaths from COVID or with COVID, but we need to take them very seriously. Also, we need to realize that any measures, any restrictive measures that we try to take to reduce the spread of the virus, if they're severely affecting our society, our functions as human beings, eventually they will backfire. We see tremendous increases in domestic violence. We see increases in alcohol use, in drug abuse, unemployment. We know that eventually leads to killing people in the long term. These are not deaths that we will see necessarily today or tomorrow or next week. We will see them accumulating over months and years, and perhaps 10 years or more. There's other unpredictable consequences as well. There's the big experiment of what we have been doing to our societies trying to contain this virus. We have never done something like that at that scale, at that intensity, at that level of enforcement, at that level of challenging our norms of living, our norms of living a life. And I think that there's no textbook that we can try to get some information on what that would mean in the future. There's no textbook that can tell us what that would mean in terms of catastrophic events. You know, people just losing their mind and leading to social unrest. We have seen a lot of social unrest, and obviously some of that is because of some very sad reasons, because we have seen a lot of inequality and injustice in our society, and people cannot tolerate this. But you have to realize that we're doing a big experiment, and every intervention that is superimposed on that ongoing experiment has a risk of a catastrophe at some point. What is at stake in terms of the virus? I think that Michael gave a very good picture of what is at stake. People are dying from COVID-19. There is no doubt about it. They're also dying with COVID-19. COVID-19 is contributing to their deaths. It's very difficult to separate these two components, but what we do know is that across different surveys in different countries, anywhere between 96 to 98% in some cases of individuals who die with COVID-19 have other comorbidities, other reasons that they could have died. Now, this doesn't mean that we should take this infection lightly. The experience that you have in Placer County, as I understand, is mostly centered on deaths that have occurred in assisted care living, in nursing homes. And this is a pattern that we have seen in many other jurisdictions. Across the country, we see about 40 to 55% of deaths happening in nursing homes. In Europe, we see rates similarly of 40 to 65%. Another 10 to 30% of deaths seem to be related to nosocomial infection, which is infections that happen or eventually people die in the hospital. And these are, again, highly vulnerable people. COVID-19 has the peculiarity of having an extremely rich epidemiology in terms of the risk gradients that it exhibits. Most diseases where we're struggling to find risk factors that would tell us who is at higher risk and who is at lower risk, eventually we find some risk factors that may double the risk or increase it by 1.5-fold. In COVID-19, we have risk factors that modulate the risk more than 1,000-fold. If you compare the risk of death in children versus very elderly, vulnerable individuals, the difference in the risk of death is more than 1,000-fold. If you compare someone who's a frail health individual in nursing home, has a 25% chance of dying if that person is infected, more or less. For a child infected, most of them, they would be asymptomatic, they would have no problem. Most young adults, most of even middle-aged adults, even most elderly people who have no health problems will not really have a problem. So this is good news in the sense that if we use that information to selectively protect that part of the population who is at high risk, and we are successful at protecting that segment of the population, then we can do extremely well. A huge debate about COVID-19 is what is the infection fatality rate? Meaning, if you divide the number of people who died with this virus by the number of people who were infected by this virus, what would that look like? And you see some quotes that vary substantially across different counties and states and countries, and probably this is not surprising. If you take your county, for example, as Michael mentioned, you have a case fatality rate that is about 1%. If 1 out of 10 infections has been detected, this means that the infection fatality rate in your county might be in the range of 0.1%. If 1 in 5 has been detected, then it might be about 0.2%. This is something that I understand that my good friend and colleague, Julie Parson, is trying to get at with a seroprevalence study. And it would be very interesting to see what that looks like. But the reality is that infection fatality rate is not a fixed number. It is something that is up to us to modulate and to change, and hopefully change in the right direction. For example, if we let nursing homes unprotected, if we let vulnerable people unprotected, and they get massively infected, then our infection fatality rate and also the number of deaths that we will report and we will accumulate will be very high. Conversely, if we protect that small fragment of the population that is at high risk, then we can hopefully avoid the large majority of deaths. You can think of 60% of deaths being nursing homes and 10 to 30% being hospital-related deaths. That immediately amounts to 60 to 90% of all deaths that could potentially be averted if we use very draconian measures to protect these people. We need to balance everything, and we need to balance everything continuously because I think that the epidemiological picture might change, and we just don't know how it might change. Do we really need to have 60 to 80% of the population being infected before this pandemic goes away? This is what some initial models suggested, but to be honest, we just don't know. And I think that this is very unlikely. I think that there are some locations probably where you have extremely congested circumstances like homeless shelters where we have seen extremely high rates of infection. But in most communities, if you take into account the heterogeneity in the dispersal of the population and the heterogeneity on how people interact with each other, meet or do not meet with each other, eventually the rate of the proportion of the population that needs to be infected is much, much lower. It could be 30% in some locations. It could be 10% in some others. It could be even less than 10% in yet some others, especially if the heterogeneity of mixing is very dramatically different across different subpopulations within the community. I cannot tell you exactly where Placer would be in that continuum, but based on the fact that you have done so well so far, I would suspect that probably you're on the end of the spectrum that has the most optimistic features. Does this mean that this will necessarily be the case downstream? I cannot promise you that. You need to keep very close eyes, and I see that you have competent supervisors in your group, and I'm sure that they will do a great job to try to track what is your capacity in terms of hospital beds and how the epidemic wave is evolving and how things fare on a weekly basis. But in principle, I think that you should dare to open your society, open your community, still be vigilant and very carefully track what is going on, but keep some sense of optimism. I cannot promise you that there will be no new wave in the fall. I think that Michael is very optimistic. I share his optimism, but we just don't know that. We don't even know how big the new influenza wave will be this winter. Each winter is a new winter. We just don't know whether it will be an influenza that will kill 350,000 people or 700,000 people, or maybe it will be like 1957, where 1 to 4 million people died of influenza. But I think that we can have some optimism, and we can also look forward to balancing the risks versus the benefits pretty efficiently. Thank you again for inviting me.
Thank you so much, Dr. Ioannidis. We really appreciate you taking the time this morning. Any clarifying questions? It looks like Supervisor Wygant has a quick question for you.
Yes, thanks, Dr. Ioannidis. I read an article that you wrote back in the middle of March, and I think all of us were extraordinarily thirsty for information, and as both of you have just testified, we still don't know a lot. But your prediction for the death rate was, as compared to the World Health Organization's death rate prediction, was over 10 times what your article stated. And in retrospect, it just seems like there was so much sensationalizing, as there is so often today in the politics of everything. But that's a lot of the information that was coming across our table and of course getting into the press. So I wanted to point that out, and then it just kind of ask you, it sounds like your recommendation is that we need to focus on adaptive management and be ready to adjust to anything that might come up as we learn new information. But do you have what would you think would be the biggest thing that we should try to avoid, or the biggest potential mistake or mistakes that the county might make if in fact we were free to craft our own individual policy?
Thank you for this very interesting question. So back in March, I wrote this paper in STAT, trying to say that unfortunately we're making major decisions without having any reliable evidence. Our data were very poor, and I gave a spectrum of potential predictions that varied from anywhere from 10,000 deaths in the US up to 40, 50 million deaths globally, because the type of information that we had back then could not really exclude any number within this vast spectrum that was 100 or more fold different. And I think that many people mistook that as if one would say, oh, it's going to be only 10,000 deaths. And obviously, that's a very wrong way to read that paper. And I can't see how anyone could read it this way when I said that we just don't know where exactly in that spectrum we might land. Based on what we know now, it seems that we're landing closer to the more optimistic end of the spectrum. And clearly, we're not going to deal with 40 to 50 million deaths, at least with the virus that we know so far. As I said, it's a virus that there's still a lot to learn about, but even under pessimistic assumptions, it's extremely unlikely that we will land anywhere close to that. In many communities, the numbers are very close or even lower than the equivalent of 10,000 deaths. In many others, they're higher, substantially higher. And this is why we need to be very, very careful. I cannot tell you to just not take measures and just forget about it and it's just something that will go away. That would be the wrong recipe. I think that measures that are tailored to individuals, that do very little harm to the economy, to the society, to the structure of our life, are likely to be beneficial. I mean, we know that hand washing is beneficial. We know that masks, when worn in the right setting, they're beneficial. We know that social distancing in situations where you have an active wave, an active epidemic wave, hopefully can curtail the number of infections. But more generalized measures, more restrictive measures, more aggressive measures, they can have a lot of harm and perhaps no benefit. I mean, for example, lockdown supposedly saved some lives according to the Imperial College model, but actually we looked at the two models that Imperial College used and we cross-applied the model that they used in the US in Europe, and we saw that when you do that, you see absolutely no benefit from lockdowns. We actually saw that in many other countries that they didn't report in their Nature paper, lockdown had no benefit with any of their models. They just didn't report on that. So I would be very, very cautious with aggressive measures. I would be vigilant. I would be optimistic. I would be ready to adapt to new circumstances.
Thank you.
Thank you very much, Doctor. We really appreciate your input, and we'll move on to our next panelist.
Thank you.
Up next, we have Dr. Julie Parsonet. Dr. Parsonet is a professor of medicine, infectious diseases, and population health at Stanford University and specializes in adult infectious diseases. She's had continuous funding from the National Institutes of Health for over 25 years and was chief of infectious diseases and geographic medicine at the Stanford Department of Medicine from 1998 to 2001. Dr. Parsonet graduated from Harvard and Cornell universities, and she and her team are currently overseeing the Placer County seroprevalence study. Welcome, Dr. Parsonet.
Thank you very much. And I first want to thank all of you at the Board of Supervisors for all the work you do. It's a challenging time, and we all in the state appreciate the hard work of the public servants and everybody who works in the county trying to keep everybody safe. I particularly want to congratulate Dr. Sisson, who I have talked to several times on the phone, and I totally admire and think she's done a terrific job, as is really evidenced by you getting off the monitoring list. I think that's a great accomplishment and is a real testament to doing the right things as things currently stand. I can't really see, are my slides up? So I was asked to bring some slides, so I just want to make sure those are up.
Yes, we are bringing them up. Thank you.
Oh, by the way, my background is Antarctica, just to cool you guys down a little bit.
We really appreciate that. Thank you. We need a little cool air in here.
And I spent 6 months there, and it was nice and cold. All right, so we've been asked to do a serosurvey in Placer County, and I'm going to talk a little bit about serology. Can you go to the next slide, please? That's the last slide. So if we can go back to the next slide, there we go. Okay, so I'm going to talk a little bit. I'm just going to outline what I'm going to talk about in my few minutes here. I'm going to talk about serosurveys, why we do them and what they are. Then a very brief outline of what we've proposed for the county. Then I'm just going to mention quickly what Stanford is doing in COVID in case there are other areas that you want to collaborate with Stanford, and then some final thoughts. And I will mention that I disagree with some of what Mike and John have said. As a person who comes from a more public health background, and I'm happy to raise those issues when we get to the question and answer. So next slide, please. So on the left, is a picture of COVID, and those little three-pointed white blobs are antibodies. And so what seroepidemiology does, what a serosurvey does, is it looks for those little white blobs in the blood. So when you are exposed to COVID or when you're exposed to any new virus, your white cells, specifically your B cells, produce these proteins called antibodies that bind to the invader and help to kill it. These antibodies persist for long periods after the infection has gone. So even after you've gotten rid of the infection and you're back and your nasal swabs are negative, these antibodies can persist. They can wax and wane and they can drift off and go a little lower, but in general they last. And if you're re-exposed, they bump up again. So their presence can be used to indicate exposure at some point in the past. It doesn't say how long ago, but it tells you that at some point you've been exposed to this virus. So we use these we go out and we test people's blood and we look for them. And we do this to see in an unbiased way who in the population has been infected and what populations are at risk. So we can figure out, who are the people that are likely to have the highest probability of getting infected. We use them to estimate asymptomatic, or I shouldn't say asymptomatic infection, but asymptomatic or infections that didn't come to medical attention. So people had a runny nose and didn't come to see the doctor. We use these to estimate what percent of the population has had at some point been exposed and may not have been seen. So as an example, in Placer, if we find that 5% of the people has antibodies, then you can extrapolate that to the entire county and say, in the county, 20,000 people have been infected. But then again, that there are only about 2,500 cases so far. So 1 in 8 people in the county has come to medical attention by you guys, and 7/8 of the people who have had COVID in the county have not seen anybody and you didn't even know about them. And this gets to some of the issues that John mentioned about figuring out what the real fatality rate is of the virus. So we use them to estimate the infection fatality rate, which is the proportion of people who actually who are infected who die of it. We also use antibodies to understand herd immunity, and I'll talk about that a little bit later. Herd immunity is the population, the prevalence of people in the population who need to have been infected so that the virus can't spread anymore, because the people who get infection will only bump into people who are immune, and the infection can't go any further. We also use serosurveys to find out where vaccinations might have the greatest impact. And after vaccinations start, we can see their impact on population immunity. So they're very important for understanding vaccinations. So next slide, please. So I just want to make clear that serology and serosurveys are not for individual health. There is no individual benefit to knowing your serologic status right now for COVID. And that's because there are false positive tests. That's a small problem. We don't know yet how good the protective immunity is if you're positive. So if you have positive serology, we don't know for sure that you're protected. And if you're negative, you may have been recently exposed and it may be a false negative. And it doesn't really help you in terms of protecting yourself. So we do serosurveys and serologic testing right now for public health purposes. We're not doing it to give people their immune passport, which is what some people have wanted, but right now we're not ready to be able to do. Next, please. So I'm just going to mention that there have been a lot of serosurveys. This is from a website called serotracker.com, which talks about serosurveys that have been done around the world. This is incomplete. There are many more than this. But millions and millions of people have been tested around the world. Next slide, please. I will point out that in Sweden, various surveys have been done, and they suggest around 10% seropositivity. I think in the most recent survey in Stockholm, I could be wrong about that, and I'll defer to Michael for the final numbers, but they are far away from herd immunity. And in the United States, they've also done quite a number of surveys. The numbers are there up on the left, and the CDC has done some surveys, and we did a national survey of dialysis patients, and there are quite a number of surveys that have been done in the United States that are helping devise strategies. Next, please. So I just want to mention the few that have been done in California. There have not been that many. The one that's on the screen there is the CDC survey, where they took remnant serum from hospitals around the country, and the blue dots are done in April. The orange dots, I think, are done in May, and the light blue aqua dots are done in June. And you can see New York at the top, standing way out above everybody else. And all the other places are hovering less than 5% in general, 5 to 6, 7%. San Francisco is circled there. It was done in late April. San Francisco has done an excellent job controlling disease, and they have 1% seroprevalence. There are also 3 other surveys that have been done in April. One was done by John and showed a prevalence in Santa Clara County of 2.8%, Los Angeles 4.7%, and Bolinas had very, very little disease. They tested the whole city. But from these data, we've estimated the underreporting rate. And overall, people are guessing about 1 in 10 come to attention. The estimates range widely from 1 in 8 to over 1 to 50. But I think overall, we're thinking about 1 in 10 come to medical attention, and 9/10 of infections nobody hears about. That doesn't mean they're asymptomatic. It just means that they were not symptomatic enough to come to medical attention. Next slide, please. So when they've looked at these serosurveys, they've come up with lots of risk factors. And again, I don't want to really go into too much detail about these, except to say, dialysis patient, things we already know. Dialysis patients, people in assisted living, healthcare workers have higher rates. These numbers are all incredibly biased because some of these studies were done in April and some of them were done in June, and they're not really very accurate when you lump them all together. But just to say that there are some things that cohere with what we know about the risk factors for this disease and having underlying comorbidities as being a risk factor. These studies also demonstrate that adults all have about similar rates. They show children and youth having lower rates. Now we're seeing these rates going up considerably in children, so it'll be interesting to see how that changes over time. Okay, next slide, please. Can I get the next slide, please? Oh, I'm sorry, go back 1 second. So I want to point out something that Michael also mentioned. The biggest predictor of infection is population density. So you can plot out population density of the states or the counties or whatever, and the population density can explain about 70 to 80% of the amount of infection that's occurring. So when you have a ton of people living together, you're going to have a lot more infection, and that's true about congregate living facilities, jails, very high density populations where you have multi-generational families living together, and large cities. So everything is biased by density of the population. And you can just imagine if you live in an area way out in the middle of nowhere where nobody runs into anybody else, you're just not going to get it transmitted. So these, like all infectious diseases, the density of the population is really important. So the densest populations in Placer are going to be at highest risk, and that's what we see down by Roseville area rather than South Placer, rather than the more rural areas of the county. Next slide, please. John mentioned the infection fatality rate, and I just want to mention this again. This is a slide that came out of Sweden. And I just want to point out there are 2 solid lines in each of these graphs, women on the left, men on the right. There are 2 solid lines. Those are the infection fatality rates. And then there are 2 dotted lines, which represent the severe infection rate by age. And the lighter lines are people with comorbidities, and the darker lines are people who don't have any comorbidity. So, and these are based on knowing, on many estimates of who's dying. And I will point out exactly as what you heard from Michael and John, that if you are healthy and you get COVID and you're young, you're not going to die. It's very unlikely that you will die of that disease. But when you start to have comorbidities, that dark, the lighter solid line, then you start to see the death rates go up to the point where, over at age 80 with a comorbidity, at least 1 in 10 people are going to die. So that's a lot of people who are going to die in those older age groups. And then but I also want to point out something that's not mentioned, which is there's a lot of really serious illness that goes on. And it's not just mortality that we're seeing. Our hospitals are full, but they're not dying anymore. And they're not dying because we have better treatments. I work in the hospital. I see these patients. They are dying of COVID, or they were dying of COVID, but they're not dying much anymore because we have steroids and we have remdesivir, which is decreasing the mortality rate. But we are seeing a lot of young adults and people in their 30s, 40s, 50s, high productivity years who are quite sick. And even if they're not hospitalized, they are out of work for weeks on end. And so it is not, and that is very damaging also to your economy and to families and to households and to everything. So this is not a benign disease. Next slide, please. So in terms of stopping transmission, I wanted to just mention two things. And again, this was mentioned also by John and Mike. There's herd immunity, which we're not going to get to anytime soon without a vaccine. It's just not going to happen. And then there is what I'm going to call public health immunity. So herd immunity, again, is having a large part of the population have antibodies and not be able to get infection. But public health immunity is this concept that if we can get enough people who have antibodies and we do social distancing and careful public health measures, we can decrease the rates of disease and spare the population. So next, please. So I just want to point out, this is work that was done by Trevor Bedford at University of Washington, and he's just actually put out just recently. And he points out that, look at some place like Arizona. Their rates of, they got up to 25% positive tests, and they have about 20%, less than 20% antibody positivity, and yet their rates are declining. And they found that in many places around the country, that when they've gotten to about 25% infection antibody levels, that they're starting to see declines in rates of infection. Next, please. And so he came up with this model looking at what that means. So at the bottom is the herd immunity level, or actually the percent of the population that has antibodies. So you can see going from 0 to 30%. And the left axis is the RT, or the actual reproductive rate of the virus. And what you want is that number to be less than 1, and then the infection disappears. And what he found is that if you have good efforts to decrease social connectivity, you can actually, and you have some herd immunity, you can actually decrease this virus's ability to transmit in your population. So what we really want to shoot for now is not getting the full herd immunity, because it will never happen, but understanding what's going on in your community with your antibodies and trying to adjust appropriately to have the right amount of social distancing and the right amount of closing and protecting, especially high-risk populations. So this is why knowing what's going on in your population from an antibody level is very helpful. Next slide, please. So our current plan is to do a serosurvey of 2,000 people. A lot of problem with serosurveys is getting the right people, because you want to get a random sample of your population. So we're doing it by mail, and we're hoping to get 2,000 people. We're going to mail 20,000 people and hoping that we get 2,000 to respond. And we're getting multiple people per household. The first mailing we'll do is random. The second will be targeted to areas from which we did not get very good responses the first time around. Patients will do their own testing at home. They'll sample themselves by doing a finger stick and sending it back to us, and we will test it by a series of 2 tests. And we hope to finish by November, depending on all the usual things that cause delays, like contracts and IRBs and all these other things that always end up causing delays and have caused considerable delay up to now. And what will be learned, or what the high-risk areas are, what the high-risk demographics are, where to allocate education, testing, and other resources, and how you can get to this public health immunity. What kind of social distancing might need to be done to protect various areas of your population. Next slide, please. So just to mention some other things that Stanford is doing. We have a lot of clinical trials. Some of these clinical trials are open to having new hospitals join in. So if there are clinical trials in your county who are interested in joining in some outpatient or inpatient clinical trials, we invite you to tell them to call us. We are interested, Lori Nelson is doing this Google Cloud platform, which is going to be getting really detailed information about all the people in your population, that allows you to identify risk factors and things that can be modulated. And I know she's talked to Dave DeFonte about that, and about including Placer in this platform data program. We're doing a lot with diagnostic tests. We are going to be seeing a lot of new diagnostic tests coming down the line, especially rapid point of care in-home tests that are tons of people working on, and that I think are going to be very helpful in controlling this infection as time goes on, and especially as we get closer to vaccines. And then we have a lot of people like Michael and John who have been doing modeling of these diseases and trying to get us ways to interpret what's going to happen with our interventions moving forward. So I'll end with the last slide. And this is my last slide as a public health person. And I worked at CDC before coming to Stanford, and I teach about outbreaks to Stanford students, and I've done for years, and I've done a fair number of outbreak investigations in the United States and around the world. And outbreak control is always much, much more political and sociological than it is biological. Biology is very easy compared to the human aspects of pandemics. And I can tell you, though, that the one constant in every successful outbreak control investigation or control is consistent messaging. And you can see that in the countries that have done the best in controlling the epidemic is they've had a consistent approach across their population, and they've put out messages that everybody understands and is able to adhere to. My husband was a colonel in the Air Force with 35 years of service and had 6 tours in Iraq and Afghanistan. He also is an infectious disease doctor. And in his opinion, fighting a pandemic is like fighting a war. And just like in a war, you need a strong command center. You can't have every platoon getting up and saying, I want to use my strategy because my platoon is different. You end up shooting each other and it's chaos. And everybody thinks they know what to do. So there is no strategy at all. In my opinion, the command center is the California State Health Department. And if you don't agree with what they're doing, I think you should talk to them in conferences and in private meetings and tell them what you think is the right thing for you and how they should change their metrics and what the metrics are that apply to your county and why your county is different. They will listen to you, and they will also listen to John and to Mike and to all those other academics doing modeling and the people doing new diagnostic tests and new treatments and new vaccines, and they will respond. And they will change their messaging and they'll change their strategy and they will do it better. They are very aware of the economic burdens. Everybody in the public health community is, and the psychological impact. They are really aware of it and they have no vested interest in making people miserable or poor. But their message has to be the voice that everyone hears, because if it's not heard, then the virus will divide us and conquer us and it will win in the end. So I think you have to think very carefully about your strategy moving forward, because giving mixed messages is like giving no message. So there you are.
Thank you very much,
for your
Dr.
time.
Parsonet. We really appreciate your comments and look forward to the study as we move forward. Robert, question?
Dr. Parsonet, first of all, and probably most importantly, I really want to thank you again for your availability and your graciousness and sharing your wisdom. You've been tremendous help to me, unbelievably willing to spend time and point me in different directions. So I want to thank you for that. And then for the public and make sure I understand clearly, we're obviously going forward with a seroprevalence testing that you're going to be managing for the county, and I'm really looking forward to those results. But if I map on my words of adaptive management to Dr. Ioannidis said, it seems to me that the only explicitly accurate way to know our mortality rate is to also know the spread rate. And with the seroprevalence testing, we'll be able to get that with a very high degree of certainty. And so we'll know the worst impact, deaths of the disease here in Placer County. And we'll also know your words, your phrase is public health immunity, which I understand as being a level of spread such that there's a higher level of community immunity that can become partly achieved, that could be partly achieved with the vaccine, of course. And then, as we've spoken, you've talked about how we already have improved our caregiving, our treatments. So, is that messaging correct? Do you agree with that? That's the critical component the seroprevalence testing will provide for us here in Placer County?
Yeah, I think you're absolutely right. I thank you very much, Dr. Mr. Wygant and Supervisor. I think that we will know where it is, who has it, what the infection fatality rate is, and it may help you also to just figure out how intensive your public health measures need to be and where they need to be. So I think putting that all together, it gives you just a better handle on how to manage the infection from a public health perspective.
Thank you.
Thank you, Dr. Parsonet. Supervisor Gustafson has a quick question.
Thank you, and thanks, Dr. Parsonet, and all of our panelists. Dr. Parsonet, I'm interested in your final comments related to the state. Have you or have people at Stanford been talking to the state about doing such a study statewide? I mean, again,
yes, we are talking to the state about doing it statewide. We actually are doing it in 3 counties right now, in Santa Clara, Solano, and in Placer. Slightly different designs in each of those counties, but we're doing it in 3 counties. And the state absolutely wants to move forward on a statewide survey. There is a national survey that's being done by Emory, which includes California in their, they have 7 sites that they're looking at intensively. They're doing a national survey, but they're also focusing mostly on California. California is one of their 7 intensive sites. And we work with them too. They have a very similar strategy to what we're doing by mail. So I think certainly before, in the next few months, 3 months, I would say, you're going to hear a lot more results from serosurveys, and there will be a state serosurvey for sure.
I appreciate hearing that, because as you mentioned, if we are to speak with one voice, we need to share this information. And I think part of the frustration as a local public policy official is the burden of trying to interpret varying messages from varying leaders and scientific experts as we develop policies, when we see on the ground real life tragedies occurring in people's businesses and homes and those issues. So certainly understand that we need to have one voice, but we need that leadership to be looking at it as well as us going out on our own to try to develop it. So anyway, thank you.
I totally agree.
Thank you again, Dr. Parsonet. All right, we'll move to our next panelist, please.
Okay, thank you. Dr. Phil Magnus is up next. He is a senior research fellow at the American Institute for Economic Research. He received his doctorate in public policy from George Mason University, focusing on economic and policy history, political economy, and international trade. Dr. Magnus has recently focused on what economics can tell us about the modeling policy response to COVID, and has taken particular interest in alternative policy strategies such as those taken by Sweden. He's a published author and was an adjunct professor of international commerce and policy at George Mason University from 2010 to 2017. Welcome, Dr. Magnus.
Thank you for having me. And I'm joining you from Great Barrington, Massachusetts, in the very western end of the state. We are in many ways kind of like Placer County in the sense that we are a rural, mostly tourism-driven economy that is also governed by a state government in a large urban center, Boston, on the other end of the state. And we have been operating under very similar type of circumstances of conferring with our state government over how to address the coronavirus crisis in a county that has unusual circumstances compared to what we'd find in an urban center. I do want to talk today a bit about the economics of lockdowns. So I'm coming at this from a slightly different perspective than our other panelists who have backgrounds in medicine and the treatment of diseases and various aspects of epidemiology. So I'm approaching it as an economist, and an economist that focuses specifically on how policy interventions operate, how they work, and what some of the trade-offs happen to be. I want to preface this by noting that lockdowns are very difficult to interpret as economic policy because they're subject to something that economists deal with in most areas of our profession, most areas of our life when government action is initiated. How do you separate cause and effect? How do you identify whether something is actually the cause of a new pattern or trend, or if it is actually responding to other things that are unaccounted for? And one of the great complexities here, and we've seen this on full display with the coronavirus response, is that policy interventions do not occur in a vacuum. They do not take place separate and apart from what society is doing, which makes them very hard to model. Another way to put this is that human beings alter their behavior, and they alter their behavior almost instantaneously based on expectations of what they see about the foreseeable future, what they see about the policy responses in the foreseeable future. Just to use a classic example, most of us started carrying hand sanitizer, some of us started wearing masks, changing the way that we interacted with public, probably as early as mid to late February when we started to hear early word of this virus. And that certainly intensified as it moved to the United States and broke out into a severe public health crisis. What we see from behavioral responses, though, is that they make predicting the effects of policy interventions very difficult. Even in the early days of the coronavirus, we know that lockdowns were imposed in 43 of 50 states to varying degrees, but they also vary quite a bit internally from what a lockdown offers and what it does. And we see this both in the United States and internationally. For example, some of the policy variations that we've encountered is definitions of what counts as an essential business versus a non-essential business. I think this varies almost every state that imposed a lockdown. More pronounced as we've moved further through the crisis is the stringency with which a lockdown is enforced or a shelter-in-place order is imposed. And then also the length, the duration. We had states in the U.S. that reopened as early as the last week in April. We have some states that are still under a semi-permanent lockdown status that seems to be extending in various degrees. We had some states that delayed their reopening into the end of May, middle of June, and this has also shown up in quite a bit of the data. What this does is it complicates our ability to predict the course of a pandemic in relation to the policy responses. I'll preface this by noting, I believe several of our other panelists have already indicated that we were operating in a data deficit back in March when many of these policies were devised. And one of the ways that we coped with the lack of clear data about this novel disease as it's emerging was to rely very, very heavily on modeling. And several models were offered and emerged. The Imperial College one out of London seems to have been the major driver in the United States nationally to shift toward a shelter-in-place lockdown strategy. Although we also see from data that has been accumulated over the months since then that the predictive claims of several of these models have not held up all that well. I think Dr. Ioannidis mentioned the example, if you took two of the Imperial College models and cross-referenced them, applied them to the United States versus Europe as a whole, you ended up with very different results and even some evidence that lockdowns may have had a negligible or non-existent effect. We also see clear evidence that the Imperial College model, its parameters when they are adapted and basically applied and run for Sweden, yield very different results than what they predicted for a country that took Sweden's lighter touch approach of not locking down, relying on social distancing advice and some lighter touch measures. So the models themselves are probably operating in a place where we can start to question at least if that should be the priority that we're basing policy upon. We also have some modeled reopening scenarios that were put forth by Imperial College. On March 24th was when they published their main paper on that. They put out a predictive model for 5 U.S. states to ask the question, what would happen if they reopened from their state of lockdown? One of those happened to be California. They also focused on hotspots like New York, Massachusetts, that were undergoing very heavy coronavirus outbreaks at the time. But one of the things that we learned from that particular reopening model, it assumed an increase of mobility of 20%, and then another scenario of 40% from a baseline of the bottom of the closure, of the full enactment of the closure over the next several months. And the reopening scenarios that they projected vastly overstated the number of deaths that could be expected by right about now on the timeline, by mid-July to early August. Even to the extent that the California model for showing a 20% increase in mobility or a 40% increase in mobility had a range of predicted 1,000 to 5,000 daily deaths statewide. We know that's not the case. Death is still very much a problem with the coronavirus, but we know as of August 6th, I believe the 7-day moving average for California was 142 deaths. So they're off by orders of magnitude in the projections. But what does this tell us about the economic effects of the lockdowns? Because we now have a better grasp, even though we're operating under extreme uncertainty, we have a better grasp of how they have operated economically, and we have a better idea of what the disease is doing and how it is regionally transmitting across the country. We can look at some of the results of both societies that locked down and societies that did not. They basically offer us a bit of a natural experiment type of a scenario. I have discussed quite a bit in my own work the case example of Sweden. And I want to preface this by noting that Sweden is one of a very small number of countries that very consciously and explicitly took a non-lockdown approach early on in the pandemic. They did so to much consternation at the time, although their policy has yielded some very interesting results. I would not call it a complete success in the sense that they experienced a very similar acute outbreak scenario in nursing homes. Yet on the other hand, they do have very clear evidence that their curve has moved in the direction that most other societies in Europe have, and as of yet, no evidence of a rebound. But they've done so in ways that interact economically, that has put them on a better footing on some metrics than the remainder of Europe. So just to give you an idea, we have second quarter GDP data just came out at the very beginning of August for both the United States and most of the European economies. We know from the numbers that the United States posted an almost record 9.5% quarterly contraction in its gross domestic product. This is catastrophic in terms of historical perspectives. Annualized, it would extend to a rate of 32.9% for the American economy if this is extended over a year and the same rate continues. But 9.5% in a quarter is Great Depression level types of economic contraction, although the causes that we see are very different. To give you a little bit of point of comparison, 9.5% contraction in the United States compares to a 12.1% decline that came out of the Eurozone. Hard hit countries in Europe, some of those that experienced the pandemic early on and went into heavy lockdown, post much higher numbers. So Spain had an 18.5% contraction. France had a 13.8% contraction, and the UK, which just posted horrendous numbers, in part because it's still under lockdown, still has not fully tamed the epidemic, 20.4% contraction. We also know from lighter hit countries, Germany had a 10.1% contraction, Austria a 12.8% contraction, although both of those countries went into various degrees of lockdown. Sweden is actually something of an exception. They had a softer contraction than most of the Eurozone with a few caveats. They had an 8.6 decline in GDP in quarter two, and this was actually being the only country in Europe that posted a slightly positive level of economic growth in quarter one. That's what included March, so the very tail end of quarter one, we were already in pandemic territory. By comparison to its neighbors, we have data now for Norway, which has basically matched Sweden, 8.5%. Then just across the sea, Netherlands also posted an 8.5% contraction. But the caveat here is while both Norway and the Netherlands went into a much heavier lockdown scenario, they adopted policies more on par with the rest of Europe. In March and April, both of them reopened very early on. And in fact, if you measure their stringency of restrictions right now, Oxford University has a stringency index of responses to the coronavirus. Norway, the Netherlands, and Sweden are at almost exact parity right now and have been since about late April to mid-May, depending on the country. So what we are seeing is, at least in observational comparison, countries that either did not adopt full lockdowns like Sweden or that adopted them and reopened earlier tend to be doing better than their neighbors, than their counterparts, or than the US, which has gone through a mixture of policies. Another dimension of this that I'd like to draw attention to, and I provided a handout, I believe, that's been circulated in paper. And this is some work done from my colleague at the American Institute for Economic Research, also a professor of economics in Kansas, Abigail Devereaux, who has studied unemployment claims data from state level releases that have come out basically monthly since the start of the coronavirus pandemic. And what this data shows us is if we index state level insured unemployment claims, so people filing for unemployment, to March 1, so about 2 weeks before the pandemic really starts to initiate policy responses in the US, we can actually track the performance of states on a comparative basis to see how they operate, to see how they've weathered in terms of their employment markets. And Early on, several studies were done on this, and they noticed that in the first few weeks to really about the first month of the pandemic, most states paralleled each other very closely. And this is 43 out of 50 states that locked down. So by the end of March, early April, almost all of the United States is under some sort of lockdown or shelter in place order of varying degrees. And those states that did not are mostly rural states in the West that have more diffuse populations or were not hit not hit very hard by the pandemic early on. But nonetheless, it's quite a bit of data that's come in. What we start to see, though, is toward the end of April, beginning of May, is states diverge in very pronounced ways in how they are weathering the unemployment crisis. And this appears in really kind of groupings or clusters of states that we can divide, and that's what the chart in particular does. Of the 7 states that did not lock down, they're an interesting counterfactual, so we do include them in our data. They show the lowest increase in unemployment claims over the course of the pandemic. And this may be kind of obvious. They did not lock down. They did not put themselves under a situation where commerce is effectively suspended. So you'd expect that unemployment to be much lower there. But in those states, you had about a 5 percentage point increase in unemployment claims across the board on average since March 1st, since just prior to the pandemic. What you start to see, though, is the various levels of length and stringency that are applied in different states. So the next grouping of states are those that reopened after 1 month. We measured these as a metric of less than 30 days under lockdown. And what you see is a higher spike in unemployment claims, but it's about 5 percentage points added on to the non-lockdown states for being shut for a month or less. And then it starts to scale up from there. So every 10 days that's added onto the mark, you start getting higher and higher levels of unemployment claims that persist to the present day. A good rule of thumb for states to measure this is for late reopening states or states that are still under indefinite lockdown, you can add about 3 to 5 percentage points above states that reopened early. So there's a clear at least association that seems to be emerging, at least a correlation that's emerging between the length and duration and stringency of the lockdowns and the unemployment crisis that's emerging there. California is in one of the categories that we classify as an indefinite lockdown state, although there has been some level of reopening in areas that's been paused or reversed, but it falls under the category of states that have not announced at least an official end date or suspension date to the declaration of emergency. And the most recent data from California illustrates that the state is hovering around a 14 to 15% increase in state-level insured unemployment claims since March 1st. It's one of the highest in the nations, and it's persisted as one of the highest in the nations as a result of that. Another point of comparison would be that California is hovering at 10 percentage points higher than a non-lockdown state, and about 5 to 6 percentage points higher than states that have generally reopened in the period between late April and the end of June. So what does this imply about economic conditions? Well, we can now state, I think with a fair degree of conclusivity, that the variation in policy that's been applied across different economies in the United States, including the rate of reopening, the degree of stringency that a lockdown has been applied, has clear determinative economic effects on the response to the pandemic. And those have to be weighed in the trade-offs. They aren't the only consideration, but they are a substantial consideration, because human beings' well-being is often tied to their ability to obtain an income, to work a job, to support themselves, to make rent payments, to cover their mortgage and their debts, even to have groceries and food in a given week. This is all going to depend upon the ability to attain our income. So what does that imply about policy moving forward? Now that we know that there's a substantial variation, we can actually look into mobility data. We can look into data that indicates how different states or different countries are comparing as the lockdown has persisted, or as it has been alleviated in some areas of the world and some areas of the country. And what we know from mobility data, this is stuff that's taken from Google and Apple phones. What they have both done is they've released metrics of the number of people appearing in retail and recreation locations, often down to very fine grain of the state or in some cases even county level. I did map out California to see where it stood, and California almost perfectly tracks two of the worst hit states in the United States, New York and New Jersey, in the early months of the pandemic. Mobility in California declined very rapidly even before the lockdown was put in place on March 19th. So about a week before that, you start to see a very rapid decline in number of people that are going to retail and recreation locations. It matches New York and New Jersey at its peak. California was in the territory of a 60 to 70% decline in mobility from the normal baseline in a previous year. So that's makes it one of the highest declines in mobility in the nation. This lasted for about the end of March through early April, the peak of the pandemic on the East Coast, the peak of the first wave, so to speak. But we also saw clear evidence of it starting to relax toward the end of April through about mid-June. This also coincides again with the emergence of a second wave, other outbreaks that have occurred, but it also coincides in a different way with the pausing of the reopening in several of these states, even to the point that mobility in California today has now persisted at a much lower plateau. We're about 30% below the baseline, even as some other states have continued to reopen, including New York and New Jersey, the two that it closes, their tracks the most closely. So what we are starting to see emerge in the wake of differences in lockdown policies over the last 2 to 3 months, as some states have reopened and others have not, is you see variation in their economic activity that was not there early on in the first few weeks to month or so of the pandemic. What this tells me from a policy analyst, as an economist who's studying this issue, is that we need to start reorienting some of our responses to a study of empirics, of metrics that are coming in, to move away from the path dependency that we had on the early models, including models that have either failed or not proven sufficient to explain what is going on, or not proven capable to address quite a bit of the variation that we've started to see. We also know very clearly that lockdowns do carry a severe trade-off with economic health, with economic ability, not just in GDP, but also in the ability to earn an income, the ability to work a job. It doesn't mean that absent lockdowns, the economy would be fine and dandy. In fact, the coronavirus itself, because of the behavioral response, indicated with near certainty that the country was probably heading into recessionary territory no matter what we did. What lockdowns and some of the more severe policies that we initially adopted back in March and April do is they add severity to the economic harm. And now that we see variation, now that we see some states opening up at faster paces than others, we can see the level of that severity playing out in real time. Another way to put it, this would be analogous to if you consider something like a famous economic event of the Great Depression. Well, the stock market crashes in 1929 and subsequent events indicate we were heading into the Great Depression. But what most economists do when they analyze the Great Depression is they look at the policy responses in those first few years after the stock market crashes. And the United States made a lot of mistakes. It made mistakes in its monetary policy management, its international trade policy. We imposed a tariff on other countries as an attempt to protect the U.S. economy. And what these policy steps did as they persisted is they made an economic downturn much, much worse. And the question is, what level of lockdown do we accept as a component of public health, especially if we have evidence that doesn't seem to really be holding up in terms of its effectiveness vis-a-vis clear evidence of its economic harms. In other words, we know that lockdown states are now at a point of suffering greater economic suppression than states that have started to reopen, but again, with trade-offs implicit in all of that. What this means in terms of recommendations that I'd offer to both my own state, if I were advising someone in Boston, or to other states, large, especially geographically diffuse states such as California, such as Texas, that have population centers, and then also rural and suburban areas, is that we need to look at the locale. We need to look at the conditions on the ground and ask questions. Can we vary instead of the one-size-fits-all top-down approach? Can we vary at the local level and ask, are there ways to mitigate some of the economic damages that we know to come from these policies? Ask if there are ways to alleviate and put us onto a path of economic recovery as part of that trade-off while remaining conscious of public health.
Dr. Magnus?
Yep.
We do have somebody we'll have to get, one of our panelists has to leave at
and
11.
I can actually wrap up right there.
Okay, that'd be
And
great.
be happy to take any questions.
Thank you. We really appreciate your input and your expertise. Very helpful. Thank you. I think we need to move, Shanti, I think we have somebody who needs to get off the phone. I know we're running a little bit late, so I think we're going to move to Dr. Weiss.
Yep.
And sorry about that. To our other docs, Dr. Weiss has to get off at 11, and I apologize for running a little bit late. So if we'll take Dr. Weiss briefly, that would be great.
Thank you, Dr. Magnus. Harry Weiss is the president and CEO of Tahoe Truckee Hospitals. He was appointed as the Tahoe Forest Health System in December 2015. Weiss has been in healthcare leadership since 1977 with extensive strategy, acquisition, operational, clinical, and financial experience across for-profit and not-for-profit healthcare organizations and systems. He is a champion of innovation and passionate about delivering a new model of healthcare that's integrated, high-quality, compassionate, and proactive. Weiss holds a master's in healthcare administration from University of Laverne and a bachelor's degree in business administration accounting from Southwestern Adventist University. Welcome, Mr. Weiss.
Good morning, everyone. Can you hear me okay?
Yes, thank you.
Just to share with you very briefly, it's a privilege to share, and I've certainly admired some of the earlier speakers and their documented work over the past 5.5 months, especially. The Tahoe Forest Health System area and the Lake Tahoe area is one of the most desired destination spots in America, as many of you know. And so we as a rural area have experienced a wide variety of change since March, where we had a large influx of people come visit us in March. We started having a lot of positive lab tests and ill patients in late March and early April. We saw that really flatline and really begin to decline, especially in the months of really June, July, and August, even more pronounced in the month of August, even though we were a very warm spot early on and being a destination spot. So far, for example, in August, we've ranged 0 to 3 inpatients, and we were 0 to 7 in the previous month with many days of no patients. Where we are seeing increases, which I think is especially noteworthy, is we look at healthcare from a holistic perspective here, as we're really accountable for all diseases and injuries. And what we're seeing specifically in our region is that mental health referrals to our mental health providers have risen more than 200% in the last 5 months as the various stresses have continued to climb. We're also hearing from our local food bank that their referrals have grown at over 600%. We as a health system have stated this for a few months now, and I don't hear it that much in the news, but I think it's a very important disease cluster, and that's the diseases of food, housing, and job insecurity, which we're seeing more of that as a holistic healthcare provider in our region. Also, the diseases from prolonged shelter in place. For example, on June 9, Becker's Hospital Review had a commentary from Mayo Clinic CEO and Cleveland Clinic CEO, and they talked about the higher acuity of ER patients that are being seen, and we're seeing that as well. And also the fact that just in the disease category of cancer, because of a lack of attention for 6 weeks to 2 months and beyond, there could easily be 250,000 additional deaths per year just in that one cluster category of cancer. As I've spoken with our radiologists, they're saying, that they're seeing more advanced tumors and so forth amongst the patient population that we see as well. When I've talked to individuals in our community, who have suggested that we should have a total shutdown, I've shared that in this region, we've only had one death of an individual who was a hospice patient, and every life is super precious, who also was COVID. So we've had one death, we've had 153 admissions, and I've shared that there will be many deaths in our region each year, but again, not from COVID-19. So I think it's a perspective of all these other matters, which should make COVID certainly look like the 1 to 3% issue. And the question is, what are we doing about the other, 97 to 99% issue is our concern, for the total health in America. So what, as we're dealing with it, certainly our lab capabilities have really increased. The turnaround in those issues have really helped. Our medical teams are doing an amazing job of caring for patients in med-surg or intensive care units. And again, no deaths in our hospital to date, and that's which I think is remarkable. And we're seeing remarkable improvements in other health systems as well, as they're really finding new ways to successfully treat. And so our theme really is just living successfully in the era of COVID-19. You've heard about those vulnerable populations. We do speak about that as well. We need to protect that. And I think that really gets to that public health immunity that's been shared earlier as well. But we're happy to be seeing a slowdown overall in the cases and certainly hospitalization. And we hope that continues in August and September. We haven't seen any science evidence that says this disease needs to repeat every year. And so we're hopeful that through a variety of mechanisms, we can beat and cause this disease to continue to lose energy over the coming months. So that's my summary.
Thank you very much, Dr. Weiss. Really appreciate that report, and good to hear that the hospitalizations in your area have decreased. That's good to hear. All right, we will move on to, I don't see any questions. Okay, we'll move on to our next panelist.
Okay, next up is Dr. Genevieve Sweet, MD, who is a urologist and a specialist in Roseville. She attended and graduated from Boston University School of Medicine in 2006, having over 14 years of diverse experience, especially in urology. Welcome, Dr. Sweet.
Thank you so much. Can everyone hear me?
Yes.
So, we've heard some amazing speakers today, and, I'm honored and humbled to be here. And I think in listening to all of this, I'm thinking the reason I was asked to speak was to offer a little bit of a local perspective, but perhaps a broad one. As my introduction alluded to, I've worked in primary care, urgent care, military medicine, and worked in public health. Currently, I'm a surgeon locally working in our own county. So I also think, what I'd like to say, hopefully is timely, as we are fortunately coming off the watch list, which is, wonderful news. And I think, we've talked so much about the data leading up to this point, and but I want to talk a little bit maybe about potential solutions or interventions or what we can do from here, because I'm sure, our board is looking to kind of make those decisions and next steps. Certainly we can't stay closed forever, but, COVID's not going away. We have to learn how to live with this virus and be smarter than it. And so I just want to focus quickly just on a few points. First of all, locally, what can we control? I'm a big believer in the precautions. I've been working with our local school board here for months, implementing safety measures for when we can get back in school, which I hope is very soon for our kids. But I'm a big believer in their effectiveness. And I think we really need to get that message out to, Placer County I think there is a bit of a political divide, and that shouldn't be the case in a pandemic. So, first off, masking, it's important. We need to do it. I want to see us be successful off the watch list, and I think that's a really important intervention. There's all kinds of arguments out there. Is a N95 better than a surgical mask, better than a cloth mask, better than a bandana, better than a gaiter? But the reality is they all offer at least some effectiveness. We know the disease is transmitted by droplets. The masks filter not all the droplets, but the larger and medium-sized ones. They reduce the jet stream on which the propulsion of the droplets are carried. So they do offer at least some effectiveness. Hand washing, obviously we know that works. Here in the hospital, everywhere you turn, within about 5 to 8 feet, there is a hand sanitizing station. And I think that's a realistic measure that we can help support our local businesses with, is getting those all over the place. Employees and waiters and, supermarket attendants and all these different positions, they should be able to turn around and wash their hands in a matter of seconds. So I'd like to see kind of moving forward with a promotion of that. Along those same lines, just anecdotally, when I go out, sometimes I see what's really lacking is the sanitization of communal surfaces. Spacing seems like it's actually been pretty good, and I think our restaurants and businesses are actually doing a very good job with that for the most part. But I don't always see the door handles and, the bathrooms and things getting wiped down, and that's, a huge source of inoculation. And so I think education and kind of promoting that shift would also be, something our board can kind of educate going forward. At restaurants, I'd like to see gloves kind of go away. I think that when there's gloves on, people stop washing their hands and we're just transmitting and moving things around. I'd rather see more hand washing than glove wearing. Moving things outdoors as much as we can. It's hard with the heat wave, but hopefully that'll settle down in a week or so. But as much as we can get things outdoors, that's been shown to be effective. There are very low rates of transmission when outdoors. I also want to talk about, our high-risk population. So moves on to my second point. Where's the money at? Where's the biggest places we can kind of intervene to keep things controlled locally? And I think there's 3. Every blip and uptick we've had in our numbers, everyone's been associated with either a skilled nursing facility outbreak or a large gathering. So I think these are areas that need to be watched very closely. Perhaps some more support and education with our skilled nursing facilities, and then limiting the large gatherings, I think for now is still a very important point. I also, as some of our other speakers did touch on, especially as we move forward and we all can't stay in lockdown, I think shifting from keeping the population contained to really helping our most high-risk groups stay safe is a really important measure. Going back a few months ago, I loved it when the grocery stores were offering, hours just for seniors, and there's still these grocery delivery services and things like that. And I think just promoting being neighborly and helping your elderly citizens at the hospitals. Fortunately we've been supported in revenue to do video visits so these patients don't need to come in. But I think other ways that we can kind of keep our 65 plus and our immunosuppressed people safe, if they're not getting it, the death rates will go down because they're the ones dying from it. And I think that's really going to help add clarity to our decision making going forward. And then, my final note as far as what we can control, individually, we also have to try and control what factors of our own health. I would love to see people use this as an opportunity to get in shape and stop smoking and, making themselves at lower risk for complication. And a big one from a public health standpoint also is making sure you are seeing your physician. So we're offering video visits. We're keeping the clinics as safe as possible. Don't delay coming in. Don't push your treatment off to where your treatment's going to be 10 times more complicated. Get your diabetes checked, get your hypertension in order, and stay up to date with your vaccine. The last thing we need right now is, a measles outbreak or, the college is filled with meningococcus or, whatever, the elderly patients all getting pneumonia when some of these things are preventable. So I think that's where we should direct our efforts going forward with the reopening. And then my final point is, as the disease goes on, we need to get smarter than the disease. And with all the data we heard, I think we're catching up. But I think along those lines, an important thing for us is, how do we define it going forward? How do we define, worsening situation? How do we define, our achievements? And I was really glad to hear from Dr. Sisson today that we are relooking at some of our watch list criteria. I think it's really important that we're looking at, among our COVID deaths, how many of them are purely from COVID. In the beginning, that wasn't being teased out. I also think our capacity numbers, unfortunately, up until maybe very recently, haven't been very useful. ICU capacity is very relative. Most hospitals could fill their ICUs if they wanted, if we did enough elective surgery. So I think using the surge capacity, or maybe defining a new term like COVID capacity, what could we really ramp up to? Those are the numbers that we really need to know about, because obviously we need to have our capacity there if we do see worsening numbers. But the numbers for those right now are somewhat arbitrary, and I do think need revision. And reaching out to our state, public health level, I think, to look at how these numbers are being defined is going to be really important, because we're only as good as the data that we can collect. So that's my perspective. I'm happy if there is any questions to answer them now.
Thank you very much, Dr. Sweet. Don't see any questions. I really do appreciate you taking some time speaking with me this last weekend as well, and always love hearing a doctor encourage us to take care of our health, which is important for everyone. So thank you so much for your time, and we will move to our next speaker, please.
Okay, up next is Dr. Ranjani Kalyan. She is an infectious disease specialist in Roseville and is affiliated with multiple hospitals in the area. Her specialties include infectious disease, internal medicine. For Dr. Kalyan, the most exciting part of this specialty is to be able to concisely explain an infectious disease condition to a patient with a unifying diagnosis by incorporating multiple specialties and subspecialties in the process. After Dr. Kalyan's infectious disease fellowship at Loyola University in Chicago, Illinois, she had the privilege of working with two of the most respected local groups in Chicago, and was later given this opportunity to join pulmonary medicine, infectious disease, and critical care consultants, where she was given a chance to further expand the infectious diseases section of the group. Working in PMA has allowed her to collaborate with some of the most critically thinking, compassionate, and skilled physicians. Welcome, Dr. Kalyan.
Oh, we cannot yet hear you.
Thank you very much for having me today. It's truly an honor to represent infectious disease and really our viewpoint locally at this level. And it was a pleasure to speak with Bonnie Gore. So, there are some stalwarts of infectious disease and epidemiologists who spoke earlier today. And I wanted to give a little bit of a community perspective as an infectious disease physician in Placer County, as well as a mom. I've been practicing infectious diseases for about 14 years now, a mom for 13 years. And I certainly recognize that my 13-year-old and 10-year-old over the past 5 to 6 months now have certainly felt removed from society with their lack of friends, decreasing self-confidence, self-esteem sometimes because of not being able to regularly communicate with their friends as they are accustomed to. Certainly the last few months of school year took a hit, although our school board and our district did a phenomenal job in trying to regroup in such a short period of time. And in this distant learning situation, they've made incredible strides in really offering an excellent education for these kids in the earlier grades. So while education is still something that we expect to see the teacher and our friends in learning, there are of course these extracurricular activities that these children are involved in that they're no longer able to as easily as they were in the past. So we clearly see that children are affected socially, emotionally, behaviorally, perhaps with some children, and of course earlier it was discussed the economy that was hit, and so in various ways, in children, adults, the community has been affected, as we know. So we're trying various measures to get past this hopeful blip, and I am optimistic that we'll get through this in order to evaluate how this virus and disease treats us and how we can manage it going forward over the several months. Now, I just want to step back a little bit because I want to take a viewpoint as an infectious disease physician and not as a mom, because I very frequently have to go between the two to assess the risk and benefit of exposing the community to this infection and what I do see in the community. I'm really thankful for Dr. Sisson's evaluation, and looks like we're coming off the watch list, which is wonderful. I do want coming off the watch list is one thing, but I also think we need to keep ourselves on the watch list in the community, at the hospital, at multiple levels. We need to continually see how this virus behaves and what measures we may need to take at the local level in order to mitigate the effects of the virus. I think Dr. Parsonet from Stanford said it, really I have to underscore what she said, in that in a pandemic situation, I have been trained to follow just what, we're sort of we are in a war against this virus. And in this situation, we just, I, as an infectious disease physician, am a soldier at the hospital in fighting this virus, and would take the orders, so to speak, from the county as well as the state. And I really think that universal message that comes down from the state is really important in a pandemic situation, because there are several unknowns. When we initially started off on this journey, there were so many unknowns that really we came to a really tight lockdown. That lockdown allowed for us to have some plateau in our numbers, certainly. However, with each holiday, we noticed increasing gatherings, family gatherings, or people traveling to see their family members graduate. So there was a lot of travel up and down the state that would end up in hospitalizations. To where we are now, at our hospital, we're seeing probably the highest number of hospitalizations, and where we used to see 65 plus hospitalized, we're now seeing the 20s, 30s, and 40s, 40-year-olds that are getting admitted. Where they probably may not have otherwise gotten admitted if it was a flu or an asymptomatic or a minimally or a mild infection that they may otherwise have had. Here, these young people are getting admitted with, certainly some have comorbidities and others don't. So I think there are still some risk factors, as someone had mentioned earlier, that we may need to continue to look at as to why some are presenting in a more severe situation as opposed to others who might be asymptomatic or mildly ill. I'm sort of, it's staggering to see that the young people requiring increasing oxygen needs, where after several days of being evaluated and monitored, they'll suddenly require a jump in oxygenation and require some high flow oxygen that then takes them to the ICU setting and then bring them back to the floors. Of course, as we see the data, the young people are not dying, but the increasing numbers of young folks coming in is surprising, and the duration of illness and the duration of hospitalization hospitalization is quite surprising to me, as I see these patients regularly. While we do have treatment options, again, these are emergency use access, medications for certain, the convalescent plasma that's out there. We have to be on a trial. So it's not easy in trying to treat these patients. And what we're also seeing in the last month is that once these young folks do have that prolonged hospitalization I was talking about, they go out and then they're starting to come back a week or two later with either COVID associated inflammatory changes, or their underlying disease may flare up as a result of the recent infection. So there are still a lot of things about COVID that we're recognizing that's new to us. And so when I start to see these repeat hospitalizations in these young people, that's a bit concerning to me. Certainly when I interview some of these patients, they sheepishly look at me and explain that, yes, I was traveling here to another hotspot in California, or they did. Some have even openly stated that they've been exposed to people who were positive in their family gatherings. So many of them would say that this infection could not happen to them. They are otherwise well and young, so they felt well enough to participate in many of these gatherings. And to me, what affects me most is that I see that these are the people who are most productive to our community, to our county, where they should be working, where the businesses require them. They're being removed from that environment and into a hospital environment where they may not have otherwise been. So it's really the productive years, as I think Dr. Parsonet had mentioned, is being taken away during this time of illness. So whether it's the businesses that employ these folks that are coming in, or whether these are healthcare workers that are getting ill as a result, it's really quite a bit of patients that we are seeing. The other piece of this, the young people getting affected, that's concerning, is that, of course, when they live with multi-generational families, you have the immunocompromised and the elderly, who, of course, the younger ones go home and expose the immunocompromised and the elderly that are more susceptible to not only getting sick and ultimately dying. That really increases the risk that I worry about, especially going into this flu season. There's a lot of unknown uncertainty with the flu and COVID. Flu in itself, as someone had mentioned, is to be taken seriously, and several people die of the flu. And now with what we may anticipate in the going towards the fall, I would be cautious in how I would start opening up. While we are seeing promising numbers, I would like to see a steady decline in numbers for a period of time before we readily open up. I think that's really my greatest concern and question, is that as we really should be listening to the state and national public health departments, and certainly our county public health officer, we really also need to be looking at resources for those areas that are being hit by not opening up, which we talked about earlier, and others have mentioned: the psychological, the social, the domestic violence that might be increasingly seen during this lockdown or during these times. I think that's really what I'd like to see the resources being attributed to. And what do we do as we do open up cautiously in terms of testing. And I'm glad to see that Stanford is partnering with multiple places, multiple hospitals throughout the state, whether it's the schools or various businesses. How are we testing the teachers or the students when they do present with symptoms coming fall, either with, because not every cough or a sniffle or congestion is COVID. Yet that is the foremost concern that everyone would have. So what measures and infrastructure are we going to put in place in order to address the testing situation? So all in all, I think I just want to leave more time for questions if anyone had any. What we do see is very significant in terms of the illness that these younger people are now presenting with, who then place the elderly and the immunocompromised at greater risk. And the second point is, I really think we need to have a uniform and standardized message, so to speak, in order for the community to stay safe and to return in a steady approach. So that's all I have. And if anyone has any questions, I'm happy to answer them.
Thank you so much, Dr. Kalyan. I do believe Supervisor Euler has a question. He's on Zoom, so let's bring in Supervisor Euler to ask his question.
Yes, quickly, thank you. You've referenced younger people as a category. Do you have an approximate age range you're talking about?
The 18 to 49 is really where we're seeing the increasing numbers that are being hospitalized.
Okay, so you're not talking about the typical student ages.
Right. The younger folks, our hospital, actually, we don't admit them here. They're usually transferred out. But the ones I'm talking about are the 18 to 49 age group.
Okay, thank you.
All right, thank you so much. We appreciate you taking some time, Dr. Kalyan. Really appreciate it. Thanks for taking care of those patients in the hospital as well.
Absolutely, thank you.
Let's see, we have our next panelist, please.
All right, this is our final panelist, Dr. Melanie Trowbridge. Dr. Trowbridge is a psychiatrist in Roseville. She has been in practice for more than 20 years. A significant portion of who Melanie is can be credited to her undergraduate Christian education, where there existed an intentionality and discipleship of the mind taught by educators who had first learned this themselves and were passing it on to the next generation. This undergraduate foundation was the scaffolding for her further postgraduate education and career advancement. With a background first in general medicine and subsequently in various areas of psychiatry, she understands that bio-psychosocial spiritual integrated persons is her passion. Dr. Trowbridge received her MD from Medical College of Ohio and her BA Biology from Mount Vernon Nazarene University and is a California Medical Board licensed physician psychiatrist. In addition, she is a child and adolescent psychiatrist with UC Davis Fellowship and adult psychiatrist with UC Irvine and the UC Davis Residency. Welcome, Dr. Trowbridge.
We need to have you unmute, Dr. Trowbridge.
Okay, can you hear me?
Yes, thank you.
Wonderful. Okay, appreciate the opportunity to share with you this morning. Thank you so very much. I'd like to speak with you regarding aspects of the novel coronavirus from a vantage point of, a clinical vantage point of working in Placer County as a private psychiatrist, as well as a university professor. So I'd like to offer some points of consideration where these two particular roles intersect with COVID-19. I'm joining you here from Arizona, actually, because the third hat that I'm currently wearing has to do with transporting our daughter to Arizona into her first year of vet medicine under this veil of COVID. So I am especially keen and aware of our college and graduate population right now and how they're weathering this particular issue. The college population is in the limelight for obvious reasons. And because of well-documented data and certainly academically noteworthy meetings that we're having around college students, we have some visibility to the effects of COVID-19. This visibility may be extrapolated to the broader population, I believe, because it represents a meaningful portion of our citizenry and our business community. A 2018 National Health College Assessment published by the American College of Health Associations found that 1 in 4 of our college students had some form of diagnosable mental health illness. And 44% had had symptoms of depression within that last year. Further vital findings of that particular assessment that predates our novel coronavirus environment were that 86% of our college students felt overwhelmed, 68% felt sad, 63% very lonely, 62% experienced overwhelming anxiety. And of significant and particular concern to me was that 53% acknowledged feelings of hopelessness, which many of us in the mental health provider arena find concerning because hopelessness and lack of hope is very equivalent to concerning areas and severity of suicide. And then 41% depressed to the point where functioning was difficult. Finally, suicide continued and it continues to be a leading cause of death in college students. Right now it ranks number 2. All right, let's fast forward just a bit to current times. In late spring, a survey of our college students published by Active Minds specific to COVID-19 reported this. 91% of our students reported anxiety or stress. 81% sad or disappointed. 80% very lonely or isolated, and 56% had relocated, with 48% reporting financial setbacks. Similar surveys reported in late July in Inside Higher Ed also gave voice to concerningly higher rates of depression and other mental health concerns in our college students. All right, so these complexities that we are in our county grappling with are also the topic of robust discussion in a late July meeting of the American Academy of Clinical Psychiatrists and current psychiatrists. It's well studied that college students are especially prone to feelings of loneliness, and they experience higher rates of anxiety and depression compared to the general population. We know that. But during the period of social isolation, uncertainty, and abrupt transitions, they're prone to even further worsening of those signs and symptoms. So expert analyses from that meeting detailed that anxiety has seemingly become a feature of modern life, and that in our culture, which has taken a prominent emotional tone of fear, tends to promote cognitive distortions in which everyone is perceiving danger at every turn. Certainly, this increase in anxiety that predated the pandemic appears to be contributing to further mental health concerns in our now college, university, and graduate group. While we must be vigilant in appropriate hygiene, certainly, and staying safe through social distancing during this pandemic, the group of expert analyses stated that we don't want people to stop functioning, planning for the future, and really, as it pertains to college students' cases, studying and getting ready for their careers. The experts in this analysis reinforced the critical value of resiliency, which fleshed itself out in the following ways. Developing problem solving and conflict resolution skills. Developing coping mechanisms. Being able to regulate emotions, finding optimism toward the future, having access to mental health services, and having cultural or religious beliefs with a negative view of suicide. These are all protective factors that promote resiliency. Additional protective features include the development of socio-emotional readiness skills like being conscientious, having self-management, interpersonal skills, self-control, task persistence, risk management, self-acceptance, and having an open mindset or seeking help when needed. You know, family connection is kind of a mixed bag. Attachments and supportive relationships within the family predicts good outcomes. However, conflicted, stressful, and tumultuous family relationships and or where their resources are not adequate may be a risk factor. So as a result of all these virtual expert analyses and other recent data, applications in the form of best practices and emerging trends were voiced for our college campus circa fall 2020. So quote, best practices and emerging trends include consideration of wellness and resiliency programs, reducing stigma, engagement from students, training of faculty and staff, crisis management plans, telehealth counseling, substance abuse programs, postvention support after suicide, collaboration with mental health providers, and support for diverse populations. Specific to COVID-19, campuses should consider a focus on routine, self-care, physical activity, because we all know that the healthier we are below the neck, the healthier we are above the neck, right? And connections with other people while also giving space for grieving lost experiences, facing uncertainty, developing resilience, and finding meaning. In my private practice, which is new to Roseville, I've transitioned to that county, your county, our county, because I'm also a professor at one of our county's universities. My assessment of trends this summer of 2020 are not unlike what I've previously described. Many patient signs and symptoms have been exacerbated by the bio, psychosocial, and spiritual ramifications of COVID-19. And yes, I've seen a larger percentage of college students and emerging adults in my practice now than in the past. But what I see that cuts across really lifespan development stages is the need for really what I call a behavioral health facelift, if you will. That kind of focus that the CDC comments on about population health approach, where behavioral health is not just encompassing traditional mental health like patients in a traditional private practice, but addresses overall psychological well-being along that continuum. So my practice this summer has seen what I call a resilience rundown, due in part to the many ramifications of COVID. Some are experiencing an uptick in chronic mental health struggles, while others are experiencing acute mental health challenges for the very first time. But many others, and here numerous college students and medical providers fall here, are experiencing a drain that affects and infects their ability to adapt well. So in this last group, and to that point, this resilience rundown is a newer focus of my concern in our county. And I and other healthcare provider peers are looking for more appropriately innovative ways to address this greater population more efficiently and effectively. And being mindful of the time, I'll finish there and take any questions you might have. I'm apologetic that the video didn't work, but hopefully I came across loud and clear.
Oh, yes. Thank you very much, Dr. Trowbridge, and really appreciate you, especially taking time as you're in another state moving your child to college. So I wish you all the best with that. Do we have any questions from colleagues? I don't think so. Really appreciate you just sharing with us sort of the mental aspect of how this is affecting our college students, but also the population at large. I had actually asked our public health team for some numbers, and just interesting to note that calls to our local suicide hotline are up 13% over the same time last year, and we have a 40% increase in our mobile crisis call requests. So, we've heard anecdotally that there's been increase in mental health, but just knowing that there are increased numbers of calls and people asking for help is very clear as a result of the isolation and people not having that social interaction or losing jobs or what have you. So really appreciate your time this afternoon or this morning.
Thank you.
All right. Why don't we go ahead and do we have any questions for our other panelists while they're on? Just anything that came up as we're having these discussions before we open it up to the public. Supervisor Gustafson.
Thank you. I don't know that I have questions. I am just so impressed that people took this amount of time to help guide those of us in local public policy on such profound discussions. We certainly, as leaders sitting here, have to weigh a tremendous amount of information, and I've really valued this time. I definitely have some comments to make later, but I don't have any clarifying questions at this point. Thank you.
Great, thank you. So we're going to go ahead and open this up to the public. I want, so I appreciate our panelists. I know that you have patients to take care of and work to do, and so if you need to drop off, you are more than welcome to. I don't know how many public comments that we have, but we definitely want to hear from the public. I know we've got some folks who want to call in. So as Supervisor Gustafson said, thank you so much for you all sharing your expertise. We really do appreciate it. And you can drop off if need be, and we will go ahead and start with our public comment. And we're taking, it looks like, some phone calls first.
Good morning, caller. Please state your name for the record and give your comments.
Oh, and
yes, my name is Rebecca Scalling, and I live in Loomis. First, I am heartened to see that Placer County is finally getting off of the watch list. I would also like to say that I became a statistic myself over Father's Day when my husband and I made the decision to visit our son and grandchildren. We had some meals, we played board games, and then, unbeknownst to them, of course, they had COVID, and as a result, we got it. So I can tell you from personal experience that we got COVID because we were inside without a mask. We did not spread it because we always wear a mask in public. And through contact tracing, when we learned our son's family was positive, we contacted everyone that we even had a casual distance with, and then we, of course, isolated. So that combination of quick isolation and mask wearing kept us from spreading it. And my point is that I was heartened to hear from some of the guests today, for example, the urologist, Dr. Sweet, how important it was to wear masks. And I am still disturbed when we have Board of Supervisors who openly challenge wearing masks and encourage others to do so. And I also see two Board of Supervisors that were not wearing masks. And also, I read Mr. Wygant specifically say in his newsletter that mask wearing should be encouraged but not mandated. So we're off the watch list as of tomorrow. Great. We want to open up our schools. Great. I understand the perspective of the experts basically talking about the overall damage to COVID. But the one simple, humble thing everyone can do is wear masks in public. And that is not being modeled and encouraged enough by all of the Board of Supervisors. And lastly, I would like to recognize and commend Dr. Sisson for her leadership. We're lucky to have her. So I just wanted to say that I'm going to go with her. She's the expert, and I'm going to follow her guidelines. Thank you. That was my comment.
Thank you for your comment, and I'm very glad that you have recovered. That is good news. Next caller, please.
Good morning, caller. Please state your name for the record.
Yes, Tom and Drury from the Lincoln Area Chamber of Commerce, Executive Director.
Go ahead, Tom.
Thank you.
Turn it up.
I think I'm having a hard time hearing here, but sorry about that. Anyway, I just wanted to comment that, again, I really appreciate, this is my first year at the Chamber here, and I really appreciate working with the county. We've come up with some great, the toolkit, the guidelines on our Wednesday call, and I appreciate all the help from the county. But of course, from the business community, as you know, not too long ago, we did a survey with almost 2,000 signatures and 730 comments on how the first shutdown, was devastating the businesses. So with that, now we're in the second shutdown. And again, the chamber's always had the same with the cities and counties. We want to open up. We need to be safe, but we also, again, we need some kind of a coordinated response, a plan, because right now we're sitting at 108-degree weather with restaurants, trying to provide service outside. And then we have the rumblings with the weather changing here soon. How are they going to provide service outside if it's raining and snowing or whatever? So, they're basically in limbo right now, especially when, we're talking about the school situation, education. The business community seems to be pushed off to the side, and again, we're in some kind of a limbo. So I just want to stress that, the chambers are here to help in whatever capacity we can, but we are, again, trying to promote our businesses. We're trying to, push, certain events that we're going to be coming up here, push the people to the establishments to help them out. And again, I just, back to my comment about the coordinated events, I'm really nervous about winter coming. So, that's probably one of the most frequent calls that I get at the chamber is, what are we going to do? What's the status of the state? And I think Dr. Sisson's been great. She keeps us updated. But I heard her right at the beginning. We're going to be off the list, but it sounds like gyms and everything can't open up. So, again, it's been really tough. As the executive director for the Lincoln Chamber and all the other chambers, South Placer, we're doing our best to support our businesses. And again, we're here to help if we can. So that's pretty much what I wanted to say. And whatever we can do, we're here to help.
Thank you very much, Tom. Appreciate your work in the other chambers as well in our community. Looks like we're going to move to our Zoom calls for public comment.
Suzanne Elizabeth, can you unmute your mic and start your video to give your comments?
Hi. First of all, I would like to point out something that maybe we're not addressing. That is that the increased mental health issues are partially at least due to the fact that we're in a global pandemic. We are all experiencing that. Yes, that is multiplied by the economic impacts, but the stress that we are all facing living through something we've never lived through before is likely a relevant factor in that uptick. Those of us caring for vulnerable individuals like myself are under tremendous stress trying to keep them well. My own young adult children are experiencing tremendous anxiety because they must interact in the workplace with individuals who are not being cautious. So there are ramifications from that as well. Anxiety comes from a lot of different places. Those 91% of young people cited are experiencing stress because we're in a global pandemic, not necessarily because they aren't socializing or able to attend class, but likely because their futures are uncertain, as are all of ours right now. If you take a look at what's going on in Georgia and Florida, where they opened up and had huge parties, they're experiencing tremendous upticks in COVID. So that's likely causing some additional anxiety. I think that's a really important point that needs to be addressed. Also, thank goodness we're off the monitoring list, or about to be. And I think that is a direct reflection of our county finally getting serious and people wearing masks in public and taking these more drastic, making these more drastic efforts to delay this. Yes, they're drastic, but look at the numbers. I don't think you can deny that there's a correlation there. I'd also like to take a little umbrance with the economist who spoke, it seemed important to our board that we hear a lot about Sweden once again. Sweden, in fact, per capita, has the second greatest number of deaths next to Italy, which experienced this tragedy long before anyone else. when there were very few options for treatment. So I think it's really important to look at that when we keep talking about Sweden. Also, for instance, Norway had significantly fewer deaths than Sweden. That was another country that was cited. Additionally, are tremendous long-term health complications that are not being discussed here today. And I think that I'd really like to reiterate and support Dr. Parsonet and Dr. Kalin. If we're going to open up, then we should use the protocols. We need to open up for economics, but we also need to have a board of supervisors and government giving a clear message about what we need to do so we are not thrown back into this economic crisis in the future. Take a look at the statistics for El Dorado County, our neighbor, very conservative. They have had very few deaths. They have had a much lower spread than we have because they had consistent messaging and we're not trying to fight other government entities asking us to do certain things.
Suzanne, would
finally,
you wrap up your comments? Yeah, go ahead.
I would just like to say that it's disappointing. It appears clear that while we had two people that represent what most scientists are saying, clearly many of the individuals you had speak today had been vetted and were chosen because they would reflect a specific viewpoint. And that disappoints me. I expect more from my board of supervisors to listen to all input and all ideas. Thank you.
All right, next caller, please.
Suzanne Tucker, please go ahead and unmute your mic and give your comments.
Hi, I just wanted to say that I appreciate all your guests. And I just want to make sure that before we move beyond this pandemic, which it kind of feels like people want to do, a lot of the inequities that you're finding as far as mental health issues and economic issues, they're just being uncovered at the moment because of the pandemic, but they've been there for a long time. So I'm hoping that when we get to a point where we're back to whatever we want to call normal is, that we remember that when things like this come back regarding mental health and economic inequities and stuff like that, and not just forget about them because they're important all the time, not just at this moment. Another thing, I understand that businesses are important. Of course they're important. We all want everybody to come back to normal, but we have had economic downturns in the past and we have come back from them. So I know that that's probably a big pressure for you guys, but the health aspect of this, I personally believe should be the priority. And I'm all for opening back up if we can move forward in the way some other counties have moved forward, where we mandate mask wearing, where we issue fines to businesses that are not complying with the protocols put in place. If we do those things, then I think people might be a little bit more comfortable opening. But if we're going to just open up like we did last time and let people kind of just do whatever the heck they want, they're going to do whatever the heck they want, and they're going to gather together. They're going to be at restaurants. They're going to be doing all the things that we cannot have them do unless we want to get back on the watch list again. And I also want to agree that it is not helpful, I do not believe, to have our board of supervisors openly and publicly defying the state and arguing with the state in front of all of the people in the county, because all you're doing is giving cover to people who do not want to behave the way we need them to behave in order for us to move forward. If you want to argue with the governor and do whatever you need to do that behind closed doors and speak with one voice with the state and guide the people of this county to do the things that we need to have done, and bicker behind doors where we don't have to hear it. Thank you.
Thank you. Next caller, please.
Kathleen Crawford, please unmute your mic and start your video to give your comments.
Well, it is still good morning, but barely. Chairman Gore and the Board of Supervisors. Thank you for the opportunity to hear from 8 speakers today on various issues having to do with COVID-19. The 2 that I want to stress as being the most helpful, and I took extensive notes, were Dr. Parsonet and Dr. Collian at the end. And I really appreciate the fact that they have been very clear about what is needed to continue to cautiously reopen. Dr. Sisson commented right at the beginning that we are about to get off the watch list, but this is no time to let down our guard. And we need much more consistent public messaging, and we need to make sure that that starts to also include people who are talking about returning to school. As you've all seen, I'm sure, on the news, many of the colleges which have reopened are in a week or 2 starting to close back down. Distance learning has become their fallback when so many are becoming infected with COVID-19. Elementary and middle and high school students will probably start experiencing the same thing. And as the first public speaker noted, they come back and they spread to other members of their family, other members of staff, and they just continue the cycle of infection. Sure, maybe some of the young ones don't get that sick, but we don't know really about the complicating factors, health factors. And Dr. Collian spoke very, I think very honestly about the fact that she is alarmed by some of the continuing complicating health factors in that 18 to 49-year-old group. Those are also the parents of those children who are going to be going to school. If we can get off the watch list and stay off of it for 14 days. I would love for things to go back to normal. I would love for restaurants to be reopened. But I think that public health is our first priority, and that we need to find ways to assist those businesses who are suffering. I think that the CARES Act grants to the restaurants, which the Board of Supervisors is interested in passing, is a good step. We need to do everything we can to urge our federal government and our state government to help protect those small businesses. But public health should come first, and consistent messaging on physical distancing, wearing of masks, staying in your small bubble of 10 people or less, and avoiding large gatherings is really the only way we're going to stay off the watch list. This seesawing on and off, I predict, may be a problem for Placer unless we can get that unified message going. So please pay attention to the advice that we've been given, and I really hope that the Board of Supervisors will move cautiously. Thank you.
Thank you, Kathleen. Next caller, please.
Tammy, please unmute your mic and start your video to give your comments.
Want to give her name again, Tammy?
Tammy, go ahead and give your comments.
Okay, can you hear me?
Yes, we can.
Okay, great. I just have a procedural question. How were the speakers today chosen? On what basis and on what? Who made those decisions?
So we gathered a number of physicians. Supervisor Wygant has been interacting with a number of people. I contacted a couple of physicians in the community, and we contacted William Jessup University. So we wanted to get a variety of opinions. We've heard from Dr. Sisson for the last 3 months. She's done a very good job, but we felt like as a board we need some additional viewpoints, some additional information. So those are how we got to those folks.
Okay, and my other question is, why were they not on the agenda as speakers?
Go ahead, County Counsel.
The Brown Act does not require us to notice speakers.
So do you have another question?
So you had Dr. Sisson on there, but none of these other people.
That is correct. And part of that was that we were getting people yesterday afternoon.
In actuality, Dr. Sisson was the presenter of the item that was on the agenda, and that is why her name is on there.
And so there was no agenda item for these other people?
They had the opportunity to public comment just like you all. We were basically taking it like public comment. We put those people on the agenda first or on public comment first so that we could actually utilize their time and then move forward.
Okay, I understand that, but I feel, what do I feel? When I'm hearing about public comment, I'm hearing about people that are commenting like myself and the other people here off the cuff, not vetted, not, not invited. It just seemed, and I'm trying to speak here very fairly, but it just seemed like we weren't given the opportunity to read about these people beforehand, to understand their views. I know that they were each introduced, but I just felt kind of like this information was pushed on us, and that's just my comment. Thank you.
Thank you for your comment.
Hans, go ahead and unmute your mic. Give your comments.
Hey, good morning or close to good afternoon. Let me also start out with a comment about the panel. For me, it was very clear that the three medical professionals knew what they were doing, and the three non-medical professionals had their agenda, and I wonder why they were chosen. I could speculate just to promote the opinion of some of the supervisors. So let me go, and my comments will relate to that last sentence. I have two feedbacks. First, regarding the Placer County serology study. This was on the agenda good 3 months ago. When it was approved, it was said it will take 5 to 6 weeks for the study to be finished. It's not even started yet, and it was said it will be finished in November. So we have wasted $250,000 for a project that is, by the time it will be done, 5 or 6 months late. Second, it was said in that meeting, but people had commented that this study for Placer County will not reveal anything new. Today we got the confirmation that apart from real hotspots where they for coronavirus, New York or Bergamo in Italy, who have something like a herd immunity of or serology positivity of around 20% right now. Everybody else and everything else, including Sweden, is between 5 and 10%. Why do we think we learn anything from Placer County that's different from what's widely known? We could have used those $250,000 that was said in that meeting by somebody. We should have given it to local businesses and helped them. So the second comment is now about the arguments of the non-medical professionals and about the success of Sweden and the impact of economic impact of shutdowns and so on. If you take Europe, there's really good data and comparable data. Take two categories. Scandinavia, Sweden is one of the 4 countries there. Sweden had the by far highest death rate per capita in Sweden compared to the other 3 countries, Norway, Finland, and Denmark, 10x worse. How can somebody say Sweden is a role model and is an interesting case? It's an utter failure, 10x. And the Swedish head of science, Terniet, has admitted that. Take another set of countries that are very comparable, the 4 big countries in Europe, Germany, Italy, or 5, Germany, Italy, France, Spain, and England. Germany has less than a quarter of the death rate of all of those other countries per capita, again, and it has by far the lowest GDP drop. It has a 10% GDP drop, very bad, and the Other countries have 12, 15, 18, and England 20%. By the way, I forgot the GDP drop numbers in Scandinavia. Sweden dropped 8.6%, the worst of the 4 countries. Norway 7%, Denmark 7%, and Finland only 3.2%. So whatever those panelists brought up, the statistics are completely flawed, the conclusions are completely flawed. Please, dear supervisors, don't take any of their advice for Placer County. Thank you.
Thank you. Next commenter, please.
Kevin Hernandez, can you please unmute your mic and start your video to give your comments? Kevin, can you unmute your mic to give your comments?
We can't hear you, Kevin.
We'll go to Lisa, the next caller. Lisa Larkin, can you unmute your mic and give your comments, please?
Yes, sure. I'd like to make comments on a couple of things, but I will start out saying that I agree with the majority, or actually all of the callers, the public callers that have called in so far. Not having those speakers on your agenda is not transparency. And whether or not the Brown Act requires it or not is a whole different story. You should be transparent. You should let the public know that you plan on having these speakers speaking to the public where everybody can see this information. Secondly, some of the speakers, I agree, seem to be on the side of particular supervisors' opinions, and they didn't really provide much of anything that was useful information as far as I'm concerned. The first speaker, Mr. Levitt, in fact, was quoting all kinds of statistics, but then following up with, well, I don't really know what the numbers are. This is the spread of misinformation. If you think that this person has some input, it should be, this person should be directed to the state, who has a huge amount of people working on this. People with medical experience, people with psychiatry experience, people with all kinds of data collection experience. And send that person that way instead of allowing somebody to come on here and spread misinformation. Now, Dr. Callian, I believe it is pronounced, and Dr. Parsonet, and Dr. Sisson. We've got epidemiologists, we've got people that work in the serum field, and then we've got our county health official, who are all medical experts. And those people all had the same comments, a consistent approach. You need to follow the state guidelines. Our numbers are coming down. And guess what? That's because some people are starting to follow the state guidelines and wear masks and do things to prevent the spread. And again, consistent approach on that. So, and I want to say that Dr. Parsonet, even though back in the past, the public was 100% against you spending $250,000 on a serum study because it really hasn't proved anything or going to prove anything at this point when the whole country could be doing this. And again, that $250,000 could have been spent to give that money to the businesses that are struggling right now, or other people in the public. And you know, while that's the case, she was a very well balanced speaker and has been involved in county health. And so I agree with her comments and Dr. Callian's comments, and of course, Dr. Sisson. And I think you all should get on board and start listening and promoting that same consistent message. If you want things to change, go directly to the California state and work with them on changing things. That's my comments, and I would appreciate if we could open our businesses and our schools and we can come out of our houses by you directing the public to do what they need to do so we can get out of this pandemic.
Thank you for your comments. We appreciate it. Next commenter, please.
Kevin, can you unmute your mic and start your video?
And Kevin, if we can't hear you, I do have Wendy Garrick's comments that she typed to me and sent to me, so I can also I can read those if we can't get a hold of you.
It doesn't look like he's able to unmute.
All right. Do we have anybody else on Zoom?
We do not.
Okay, then thank you, Kevin, and I will, I'll read Wendy Garrick's comment. She's the CEO of the Roseville Chamber of Commerce, and she had to get off the call. This is her comment. Thank you for your action earlier on the agenda, providing additional financial assistance to our restaurants and bars. They need all the help they can get. Also, thank you, Dr. Sisson, for your request that plaster be removed from the governor's watch list. I'm calling in today to ask you, please do whatever is possible to get our businesses reopened. Restaurants, gyms, personal services, etc. were closed down and then allowed to reopen with a number of modifications, training, and other requirements that didn't last long, and then they were closed down again. I drive through Roseville and see the accommodations made by restaurants to provide outdoor seating, additional expenses on their behalf, and now it's 108 degrees outside. Who wants to sit outside in these extreme weather conditions? And when we have hair salons and nail salons trying to make a living by providing their services outdoors when it's 108 degrees, these small businesses can be responsible. Get them open. All right, any other public comment? All right, none, thank you. Then we'll close public comment, and thank you to the commenters, our panelists. I think this is our opportunity to have any questions we've got. We can ask whether it's Dr. Sisson or anybody else. Supervisor Gustafson?
Thank you. I have a couple questions. One is, and I think for Dr. Sisson or Todd, so based on the change in our status and going off the monitoring list, first off, have we received any sort of response to our August 5th letter from the governor's office, and have we received any response to the August 12th letter that Dr. Sisson wrote?
Yeah, I'll speak to the 12th one, or the 5th one, August 5th. We did not receive any response from the governor regarding that item based on we had asked for a request for information or at least a response back. We didn't receive anything. Dr. Sisson, you want to speak to the other letter you'd actually sent?
Yeah, I haven't received a direct response from the California Department of Public Health regarding my letter, but I do know that the concept of linking coming off the monitoring list to the reopening of businesses is being discussed at high levels of state government, and that the state is reviewing and considering revisions to the state public health officer order in the coming week or two.
In the coming week or two. So, so the 14-day wait period begins potentially tomorrow, and at the conclusion of that, we may know something about these small businesses. Is that my understanding?
The timing does seem to work out that, yes, if the state gets back to us or revises the state public health officer order in the next week or two, and they change it such that you have to be off the list for 2 weeks, then the timing would work out nicely for Placer County.
The other question I have is, and I've continued to ask for some time, and I just want to see if there's any new research on how we determine that the certain businesses that we have shut down are high risk in transmission. And I think that was subject of part of our letter on August 5th, and I continue to ask that because I agree with the callers. There's a lot we can do in taking personal responsibility for our care for ourselves and our loved ones and our community by taking the recommendations of the state. My concern is certain businesses are paying a huge price for this, and I don't see the nexus, and I haven't seen any evidence of that. So whether any of our speakers or whether the state or whether you, Dr. Sisson, have any information, I understand the state has determined they're high risk, but I don't know on what basis. And that's what I've been searching for, because as these people come to me, they want answers. What could they do more? What could they do better? And so I want to try to help guide them. They have really been trying hard to understand why they can't be open.
Yeah, I mean, I think your question is probably better directed to the California Department of Public Health and the state health officer who issued that order. But certainly the rationale, and as I believe I've explained it in the past, is that the businesses that have been closed or asked to change to outdoor operations are those that, based on our understanding of how coronavirus is transmitted, are at high risk of transmission in those environments. And that is because they encourage mixing of non-household members, in many cases while not wearing face coverings, and in indoor environments where there's increasing evidence of aerosol transmission, which is very small droplets that travel over long distances, as opposed to larger respiratory droplets that are thought to only travel less than 6 feet, hence the basis for the 6 feet distancing. So that is the rationale behind why those businesses, restaurants, hair salons, have been asked to close or change to indoor operations. But again, in terms of the evidence of cases associated with those environments, that's certainly something you would need to look to the state and larger for a large enough sample size to really be seeing the impacts.
Yeah, and I appreciate that. I shared, and I think you've reviewed the CDC study on the hair salons, and the as far as I'm concerned, everybody's under the requirement to wear face coverings wherever they are, whether it's Home Depot, Costco, or a hair salon, nail salon, a gym. So that's there. There's also face shields that are part of what the state has required for those operations. So not only when you go in do you see face shields and face coverings by the employees, but again, trying to make sure that, and they're socially distancing. They are spreading people apart and using those practices. So they have done much in that regard, and certainly as we head toward the fall and potentially winter months, if we are not able to stay off the monitoring list, I want to encourage those businesses to continue to have hope that we can find a way to get them reopened based on evidence. Because I agree with some of the callers, we're not through this. We're not going to be through this, and I think there was no one who spoke to us today that thought we were through this pandemic. It's a matter of what actions we take. I think those were my only technical questions. We heard one of the speakers mention large gatherings were a vector point within Placer County. Now, certainly we knew that in skilled nursing and congregate living facilities. The gatherings I had heard that we've spoken about in the past, Dr. Sisson, were family gatherings and indoor family gatherings. But perhaps our contact tracing has produced more information on what types of gatherings have transmitted within Placer County. Do we know anything additional in the last couple of weeks?
Yeah, I think that you're correct that the gatherings that I've primarily been referring to in my previous comments are family gatherings, smaller gatherings. But I want to thank the public in Placer County for primarily following the guidance around gatherings and not having large gatherings. There are still some examples of large gatherings. We have several cases associated with a business in the county that has been having youth sports tournaments. And as I said, there's multiple cases associated with those large gatherings.
Thank you. And then finally, do you agree with, I believe it was Dr. Levitt's point that the biggest predictor is truly density in risk?
I think density certainly plays a role in risk, but only because it is it predicts how likely you are to come into contact with other people and how much contact that would be. But certainly you can have disease spread at low density if people are still coming into contact with each other. So I think at all levels of density, we need to exercise precaution.
Great. Well, the reason I asked that, Dr. Sisson, is obviously we see the pockets of where we see our zip code caseload, and it appears that density factor is certainly indicated in those where we're seeing those where the cases are within our own county. And there's a lot of concern that I hear expressed about what people are doing in the out of doors, partly because where I happen to reside, there's a lot of outdoor activity, and people are concerned whether somebody has a face covering on when they are exercising on a trail, but they are far further apart than 6 feet. If they're riding their bike, should they be having their face covering on at all times? And so the reason I bring up density is not to deny that there's a risk factor with everything we do, but also trying to help educate our public clearly on when a face covering is mandatory, when people should be wearing it, and when they might have the opportunity to take that off if they're exerting themselves out of doors. So thank you all.
Any questions from you gentlemen? No. Dr. Sisson, I have just a couple of questions. When I was speaking with a physician, and I don't know if it was brought up today, one of the things that she shared was that the ICU rate and the hospitalization rate, we've got several different metrics the state is monitoring us on, and those metrics, now we're under, really aren't very good metrics, right? Because we have surge capacity. Hospitals are a business. They can get people into their hospital beds, but we do have capacity. As you've been interacting with the state, are they focusing primarily on the number of cases per 100,000? Or they still have the same amount of emphasis on all of those metrics, or is there any consideration of not looking at some of those metrics which really aren't very indicative of the health of our community?
Yeah, the state looks at all of the metrics in determining whether a county comes on or off of the monitoring list. And so that includes the case rate, it includes testing positivity rate, as well as increase in hospitalizations in the 3-day average, ICU capacity, and ventilator availability. And so it's a little bit different for smaller counties because some of the individual hospital capacity metrics won't land a smaller county on the watch list in and of themselves. So for example, if the only metric that was above the threshold for Placer County was ICU bed availability being less than 20%, that alone would not get us on the monitoring list. That has to be above threshold in combination with another metric being above the threshold. And I know that the California Department of Public Health has been discussing its metrics and also discussing how counties come on and off the monitoring list. And one thing that they have committed to do is to put a better explanation on the monitoring page of which metrics, in and of themselves can land a county on the monitoring list and which need to be above threshold in combination with others. So, most recently, Placer County has been on the monitoring list because of our case rate and not because of our hospitalizations and ICU capacity.
Thank you. Actually, that brings up a question that I have, and it was earlier in your presentation about the test positivity rate, and that our rate that we've been tracking is different than what the state has, which is good because the state number is lower. But I think I heard that you said we might be, if somebody is tested several times, that person, if they're tested positive several times, that's included in our test positivity rate, thus our rate is higher. Did I hear that correctly?
No, it actually has more to do with the denominator, the negative tests, not the positive tests. But and we've been troubleshooting this with the state for the last week, and we're actually hoping to get to the bottom of it this afternoon. But it seems that the major reason for the discrepancy between our metric of testing positivity, which is around 9% right now in the States, which is around 5%, has to do with deduplication. It's much easier to deduplicate data on a small scale at the county level. And so when we look at testing positivity rate, we pull out people who have been tested multiple times within that seven-day window, whereas the state does not do that. However, we don't think that in and of itself accounts for the entire difference. So like I said, we've been going back and forth and exchanging raw data with the state very painstakingly, trying to figure out why our numbers are not the same. And once we get to the bottom of it, we will then switch to the state's methods so that we can present the same numbers moving forward and not be not confuse people by having two different sets of numbers out there.
Okay, thank you. And I mean, good news is that our number of cases is actually declining, right? And hopefully that trend will continue. I think one of the things that I appreciate about some of the physicians who spoke, which you've been saying all along, Dr. Sisson, is that we still have to do what we can to prevent this, right? Which is wearing face coverings and physically distancing and sanitizing our hands. That's so important. I think that's the message that we need to continue to get out to people, because even regardless of what our next steps are, we want that infection rate to go down. We don't want people to get sick. We don't want people in our hospitals. And we do want to see our business community open up safely. But I think we can't reiterate the importance, which I heard from Dr. Sweet, Dr. Kalian, I think that's right, sorry, wrong name. But we need to do what we can to prevent, and we can do that, but we have to keep at-risk populations. We need to make sure that they are taking care of themselves and separating. That's really important. So I think the good news is that our case numbers have gone down. I think our residents are doing a good job. We need to still continue to encourage people to do that as we continue to move forward. Dr. Sisson, a question now that we're in this 108, 111 degree temperatures and it's hot out there. We have some cooling centers open up in the county, which is really good. How are those being addressed with the whole concern about social distancing? So if somebody goes into the Auburn Library Cooling Center, I'm guessing they have to put in these social distance protocols to make sure people are safe. Is that happening? Is that the plan? I just want to clarify.
Yes, our cooling centers are following the California Department of Public Health guidance for cooling centers that was specifically developed to consider COVID-19. And individuals are required to wear a face covering inside of a cooling center, and then they are required to maintain distance. I will say that the usage of our cooling centers has been extremely low over the last couple of days, and so they are not crowded environments, and so that is also although I encourage people who need to use a cooling center to absolutely use it, I think people don't need to stay away out of fear of it being crowded and them being exposed. And I will say that if people aren't able to access a cooling center or have concerns about going to a cooling center, they can call 211 and they will be connected with additional supports and resources to help them troubleshoot their individual situation. And if people do not have masks or face coverings when they arrive at a cooling center, those face coverings will be provided.
Thank you. Supervisor Gustafson has another question.
I apologize. I forgot to ask this, Dr. Sisson. First off, thank you for the announcement on the testing results coming back quicker. I know some of our surrounding counties, and I had dinner with a county supervisor over the weekend from another county, who have all implemented the rapid testing and invested in that. Should we be doing that? And if we, should we be allocating funds to get rapid testing here in the county so that we really can be more expedient in getting results to people?
Now, when you say rapid testing, are you referring to the point of care test that can give results in 10 minutes? Or do you just mean having the PCR test come back in 48 to 72 hours?
Well, I believe that what they were talking about was the immediate test. The ones that were within an hour or two is what the numbers they were telling me.
Yeah, there's a couple different types of the rapid tests. They use two different kinds of technology. One is the nucleic acid amplification, and that's the Abbott ID now that some of our clinics and hospitals are using here in Placer County. And then there's a new type of test called an antigen test, which is just now kind of catching on, and I think is probably the future of coronavirus testing, but it's not really the present. The machines aren't widely available. The federal government has promised to provide one of these antigen testing point of care devices to every single nursing home in the United States that has a CLIA waiver, basically that has permission to do these relatively simple tests. They'll be providing those this fall. However, they are not widely available at this time. I do know of other small counties, our neighbors, who have attempted to access this technology through the vendors, and they have gotten no traction. They can't get the vendors and the suppliers of the technology to even return their phone calls. So it seems quite difficult to acquire antigen testing. One of the other downsides about antigen testing is it's really only useful for people who have symptoms. This also is true for the Abbott ID now, the NAT, nucleic acid amplification technology. The sensitivity and specificity, or basically the accuracy of the tests, they perform best when they're used on people who have symptoms. And so they're not useful for widespread screening testing, such as the state has recommended doing in schools for school staff. So I think that folks at the state level and even more widely nationally are trying to figure out how best to implement these antigen tests. And it might be that we settle for a test of lower accuracy because the test is able to be done more frequently. But right now, even if Placer County wanted to access antigen tests, it would be very difficult to acquire the machines as well as the reagents needed to perform the tests.
So what is Sacramento County using? Do you know?
I'm not aware of what Sacramento County is using or how they are using it. I certainly could inquire the next time I speak with their health officer.
Well, I think
but that hasn't come up.
Yeah, I think from at least this supervisor's point of view, anything we can do to get more rapid testing results, and I don't need to dive into the science of which one, but the sooner we can get results into people's hands so that we know what we're dealing with, I think will be helpful. And then my other question was, I know that some time ago, Dr. Sisson, you took the step forward to look at our skilled nursing facilities and to do 20% testing on those. I think it was once every week so that 100% was done, or 25%. So you were testing everybody, and yet we've still seen that spread. Are there further steps in trying to protect our most vulnerable that we should be investing in as a county to really protect those populations?
Yeah, I appreciate the question. That ongoing screening or surveillance testing continues in skilled nursing facilities, and we've now the California Department of Social Services has required similar screening testing in staff in their facilities. So we continue to test both residents and staff in skilled nursing facilities and staff in other long-term care facilities. And that is actually where the majority of the cases are being identified, is through that routine testing. Once somebody comes up positive in the screening test of the 20 to 25% of staff per week, then everybody in that facility is tested, residents and staff alike, and then we do contact tracing from there. So there is still a lot of ongoing testing happening in the skilled nursing facilities. In terms of what is the best, or what additional steps could be taken to protect the most vulnerable residents, I really think our facilities, and we've had the California Department of Public Health Healthcare Associated Infections team come in and do site visits in every skilled nursing facility that has had an outbreak. And while there's small areas for improvement, by and large, our skilled nursing facilities are doing an excellent job at controlling COVID-19. The issue is that staff go back and forth between the community and the facilities every day, and they reflect whatever level of disease transmission is happening in the community. So honestly, the best way to protect staff, or to protect residents in nursing homes, is to keep the disease rate in the general community low, so that when the skilled nursing and long-term care facility workers come into the facility, they aren't bringing infection with them. So honestly, I think that is the best approach, and that is why it's very promising to see that the county will be coming off the monitoring list tomorrow, because that means our disease rate has gone down, and I would encourage to continue doing the steps that we've already been doing in terms of distancing and wearing face coverings, hand washing, and not gathering. And that will keep the disease rate low in the community and should help reduce nursing home and other long-term care facility outbreaks.
Okay, well, I just, in addition to the congregate living facilities, obviously there's other vulnerable populations. Some of those who work in the skilled nursing facilities and in congregate living. And so anything we can do, and I continue on education and really educating those communities. Should we be doing other testing for the workers and helping with PPE in those communities where people have less opportunity for PPE through their workplaces? If there's anything else the county should be doing to ensure we stay off this monitoring list, because getting off of it is great news, but I think what you're hearing from all of us is we want to stay off of it. We want to continue that progress, and we want to invest our money where it's most impactful. And so the guidance from the state, from you, Dr. Sisson, and others, is really focusing on those areas where we can make the biggest difference. So thank you.
Yeah, well, and I'll just say that there's a large amount of PPE that the county has acquired through the state that we have in our warehouse, and we are actively distributing that. But certainly, if there's organizations out there that need PPE, I encourage them to contact Placer County Public Health. For example, we've distributed a large number of face coverings to schools in anticipation of their in-person reopening, hopefully relatively soon. And I know that the state has also provided PPE to schools, but we want to make sure that kids and staff are adequately protected and are wearing face coverings when they do return to class in person.
Dr. Sisson, it looks like Supervisor Euler has a question.
Yeah, you hear me?
Yes, go ahead.
Okay, thank you. So a concern that Supervisor Gustafson was expressing that I continue to have, and that is what appears to be the ever-moving goalposts of these metrics of what gets us on or knocks us off of any given list at any given time. I was obviously pleased to hear that we are coming off of the watch list, but it surprised me because my understanding had been that the key metrics that we were failing were both the positivity rate and the availability of ICU. And then I come to learn, well, it's the ICU, but if you're a certain size, it's kind of tucked in under with ventilators or something like that, which I'd never heard before. So I think anything that can be done to create more objectivity around these as opposed to subjectivity would be tremendously helpful. And if I heard correctly, you are working with folks at the state on that very item right now?
That is correct. We are trying to match up our procedures with their procedures so that we'll be reporting the same numbers as they are.
Okay, well, it's not just the same numbers. It's the criteria, I think, as much as anything else. And maybe I'm just not hearing correctly from meeting to meeting as to what it is that had us in jeopardy. But certainly learning that we were coming off when we still had our issue of ICU bed availability, which, as we've been pointing out, we really have no control over, yet we're being measured by. It's those kinds of things. I just don't know from week to week what it is we're actually being measured by. So the less mystery there is surrounding that, I think, will be helpful for everyone. My question really goes more to the issue of us coming off of the watch list. What does that actually mean for any of us, for your average Placer County resident, for your average Placer County business owner? What does it mean to be off of the watch list?
Yeah, and what it means to be off of the watch list is that in 14 days, our schools, K through 12 schools, can reopen for in-person instruction. It means that our institutions of higher education can reopen for in-person lectures after the county has been off the list for 3 days. Where we don't right now have immediate action as a result of coming off the watch list is for the business community. And that is because the July 13th state public health officer order is in effect until further notice. As I stated, I have advocated for the state to tie coming off the monitoring list to allowing the businesses that were shifted to outdoors or were closed under that July 13th state public health officer order to resume operations. But at this time, until the state either rescinds or amends that July 13th order, then there is no immediate impact on our business community because we have come off the list in terms of reopening.
So where right now should our businesses in Placer County be directing their communication to be most impactful in helping form public policy?
Yeah, they should be directed to the state, either to the governor's office or to the California Department of Public Health.
Okay, thank you very much.
Thank you. And Dr. Sisson, I do have one more question, and that is, we heard from Dr. Trowbridge about the increase in anxiety, depression, and college students, but in general, we're seeing mental health issues increase, right? I got the stats from our Health and Human Services Department from Amy Ellis, and like I had mentioned earlier, calls to the suicide hotline are up 13% this period of time over last year, 40% increase in mobile crisis calls request, and the calls are actually of more intense nature, a little bit more acute, more violence and abuse related calls. So we're seeing that, right? And my question is the California Department of Public Health looking at that aspect of this public health emergency? Because that's very concerning. And as there been talk at the state level about how this mental health, the anxiety, depression is being addressed when it comes to this aspect of public health?
Yeah, I think everybody, both at Placer County Public Health, other local health departments, and the state health department are aware that coronavirus is just one of many issues that impact our health, and are certainly thinking holistically about everything that impacts our health, our physical and our mental health. But I do want to make the point that although we certainly are seeing increased utilization and certainly concerning metrics in the area of mental health in terms of anxiety, depression, suicidal ideation, I think it's very difficult to tease out which aspect of our current stressful times that we're living in is the cause of that. Certainly we have increased social isolation because of stay-at-home orders in efforts to control coronavirus. But we also have a lot of stress and anxiety associated with the virus itself, and rightly so. And then we also have, we're living in a time of great civil unrest as well as a lot of political tensions in our country. So I think all of those factors are contributing to some of the mental distress that our residents in Placer County and across California are experiencing right now. So I wouldn't want to oversimplify it and blame everything on sheltering in place and stay-at-home orders. I think it's quite complicated.
Well, you're right. I mean, it has to do with people feeling anxiety over the disease, but also losing jobs, the isolation. I think it's the whole thing, right? So I just think that's something that we need to take a look at as how this is affecting us emotionally, mentally as well. All right, it looks like no other questions. All right, I want to thank you for your time, Dr. Sisson, and I think this was really helpful for us to hear from a number of other folks as well. And we specifically had a variety of opinions actually on that panel because we needed to hear from, these weren't just sort of everybody who thought the way I thought. We had people who agree with our public health officer. We have people who have different perspectives. And I think for us, that's really important to hear some other perspectives as we look at, for us as a community, our next steps. I want to encourage folks to continue to be vigilant. That's what someone said. In principle, I appreciated was Dr. Ioannidis. In principle, open up society, still be vigilant, be adaptive. We still need to be vigilant. I think there's a desire to open up our community more, but we still need to be vigilant and we need to be adaptive. I think that's something we'll continue to talk about as a board.
And I wanted to agree with that. I think that the panelists, in my mind, and I heard the public criticism, but I thought we heard a real divergence of different ideas and thoughts from the panelists. So I appreciate those of you who put together the speakers. I know some were coming in actually as of this morning, so I appreciated how much work that takes to pull together these sorts of experts and hearing those different opinions. And I think all of us up here and most of society is listening to a wide variety of opinions, and that's the challenge we're facing in public policy. Everybody has become an expert in how to deal with this, and none of us are. None of us have all the answers, and so some of the frustration, that I wanted to share is just how much anger and blame and protesting and social unrest is starting to occur over this, has been occurring, but is growing and growing and it's not healthy for communities. And so I do agree with trying to get a message out that is consistent, but I can't seem to get a message and explain that rationally to many of my small business people, to my fellow residents. Is it safe or not to get their hair cut? How does that differ from being in Home Depot or Costco? Because proximity, you can be in line at some of these places and be very close for a long period of time. So, I think trying to resolve this anxiety and calm everybody that we're not here, I don't think any of us up here are flying in the face of any evidence. There's conflicting information out there for us to work with. And that leadership, whether it's at the federal or state level, and now here we are at the local level, trying to come up with a method to guide our residents to be safe and secure. And it isn't easy. It's hard work. And I laughingly say I should just have a big target on my shirt or on my mask everywhere I go, because whatever I do is somehow wrong to somebody. But I do think, and I want to let the public know, we're doing our very best to hear all the information, to hear all the opinions, and to come up with a way for our county to be economically stable, to allow people to earn a living and get back to work where they can in a safe manner. No one has advocated for people to not be safe. And so I do resent when we are attacked for that. I don't think anybody's asking anyone to take risks that they shouldn't take. and some need to be protected more, and I hope we can really focus our energy on that. Thanks.
Thank you. All right, we are going to move to closed session. County Council?
The board will now adjourn to closed session to consider one item of anticipated litigation.
Thank you.
chair. You're the acting chair.
Are we ready? I didn't know she was like leading anything.
She is.
She's gone. The board has returned from closed session and county council will report out.
The board met in closed session to consider one item of anticipated litigation, initiative of litigation. The board heard a report, provided direction, and requested that this matter be continued to the August 25th agenda. That concludes report out of closed session.
And with that, we are adjourned. Thanks for everyone, to everyone.